this then leads to or decreased muscle proteolysis, and then obviously if there's muscle breakdown that's limited and you actually build a muscle, you can improve survival, quality of life, and other consequences. So this is one study. There are several studies that have looked at the impact of nocturnal nutritional supplement. Here you can see daytime nutritional supplement and nighttime nutrition, and looked at 3 months, 6 months, and 12 months, randomized trial of 103 patients with cirrhosis, and you could see the statistically greater improvement in total body protein state over time, and this led to improved health-related quality of life significantly at 12 months. So keep in mind the importance of nighttime nutrition. Now, branched-chain amino acids and aromatic amino acids. This has been a controversy for quite some time. Normally, the branched-chain amino acids, valine, leucine, isoleucine, are much greater level relative to aromatic amino acids. And this is in a normal individual. The ratio is 3:1 of BCAA to AA. But in chronic liver disease, the ratio almost becomes 1:1, and this is a consequence of several processes, such as the use of branched-chain amino acids as energy, and it also is used to dispose of ammonia in the skeletal muscle. And as a consequence of this, there is increased permeability of the blood-brain barrier for ammonia, and there's also a decreased cerebral blood flow. And so replacing branched-chain amino acids and altering this ratio may potentially be beneficial. So if you were to look at potential benefits of branched-chain amino acids, you could see that potentially they could prevent and treat cachexia. They may help in regeneration and also, of course, help in treatment of hepatic encephalopathy. And these could all lead to improvement in quality of life and potentially survival. However, if you were to look at the Cochrane meta-analysis that was done in 2003 of 11 randomized controlled trials involving 550-odd patients, where they used branched-chain amino acids and looked at them in comparison to any kind of control. Survival was not impacted upon, and adverse events also were not impacted upon, although the rate of improvement of hepatic encephalopathy was greater with branched-chain amino acids in this Cochrane meta-analysis. There are other studies, smaller studies, that have looked at the role of branched-chain amino acids compared to, say, lactoalbumin or maltodextrin, and there's been some benefit while others have not shown any benefit. So for this reason, people really wonder about the benefit of branched-chain amino acid, particularly when it is expensive. When I go around the world, the use of this is variable across the various countries. Exercise. A couple of words about exercise. If you were to look at aerobic exercise, it improves skeletal muscle functional capacity, but what promotes skeletal muscle growth or increase is resistance exercise. So something that you need to keep in mind and advise your patients. There's several mechanisms. Possible mechanisms include increase in phosphatidic acid in the muscle that directly stimulates mTOR signaling. They might activate insulin growth factor 1, which increases mTOR and downregulates muscle breakdown by the UPP pathway. Drug therapy. Now, there are some exploratory studies looking at myostatin antagonists. This is a myostatin antibody that was looked at in older, weak people who had repeated bouts of falls. a proof of concept, randomized phase 2 study, looked at appendicular lean body mass. There was an increase in those who were given the myostatin antibody relative to the placebo group. There was a total fat body increase in those who received the antibody relative to the, there's a decrease in total fat body mass in those who received the antibody. And then if you were to look at change and the minimum time for a 4-step climb was reduced in those who received the antibody, and the gait speed increased in those who received the antibody. So there's some benefits that were been demonstrated in this phase 2 study with a myostatin antibody. There were some injection site reactions as an adverse event. Now, what about testosterone therapy? This has been shown to increase muscle mass in patients with cirrhosis and low testosterone. Is a randomized controlled trial. Total lean mass progressively increased in the testosterone group. Fat mass progressively reduced in the testosterone group. However, mortality was not significantly lower in the testosterone-treated group. So while there is some benefit over 12 months in terms of increase in lean muscle mass, there was no impact on mortality with testosterone. At the last American Association Study for Liver Diseases meeting, there was a very interesting and impressive study presented on the role of growth hormone therapy in patients with decompensated cirrhosis. 34 patients were randomized to standard of care plus growth hormone, and the comparator was standard medical therapy. And you can see here in Group A, which is the group that received growth hormone compared to baseline at 12 months, there was an increase in BMI, there was an increase in mid-arm muscle circumference, hand grip strength, IGF-1 went up, whereas in Group B, there was a placebo group, there was actually no change between baseline and 12 months. So these, in a small study, it appeared that growth hormone was safe and effective in patients with decompensated cirrhosis, where it improved parameters of malnutrition such as skeletal mass index, BMI, mid-arm muscle circumference, and hand grip strength. So something that we need to keep in mind. So to summarize, if we were to look at potential therapeutic strategies for sarcopenia and cirrhosis, we need to go with high energy and protein diet, and talked about at least 35 kilocalories per kilogram per day. That's a calorie intake with a protein intake of about 1.5 grams per kilogram per day. A late evening snack is important. I talked about branched-chain amino acid supplementation, which is somewhat controversial. If you're going to use it, it's around 0.25 grams per kilogram per day. Exercise, resistance exercise is important. And there are several mechanisms by which you can see benefits in these patients. And then if you were to look at the drugs or the therapeutic targets, you can look at testosterone supplementation, zinc, vitamin D supplementation, and important. Ammonia lowering strategies are beneficial. Now, reversal of portal hypertension theoretically may provide some benefits, such as TIPS placement, and then myostatin antagonists may be of help as well. But these are all still at a preliminary stage, and we really do not have large-scale studies to demonstrate their benefit. Now, a couple of words about sarcopenia and liver transplantation. Now, there is a particular phenotype in the liver transplant recipients that you should be familiar with called sarcopenic obesity, where there's increase in fat, but there is a decrease in muscle mass. These patients after liver transplant gain weight, and it's on an average 5 to 9 kilos at 1 and 3 years post-transplant respectively, but it is fat weight. And then if you were to look at these patients, there's a lot more fat than muscle, and this is what is called sarcopenic obesity. And the medications they're on, the immunosuppressants, contribute to ongoing muscle loss and delayed regeneration. So you need to keep this in mind. While they might look on surface to be reasonably well nutritionally replenished, their muscle mass is lower. So we need to advise them on exercise and obviously try and pay attention to weight gain. So on that note, I will end, and hopefully we'll have some time for questions later. Thanks very much.
Thanks, Mr. Rajendra Reddy, for very nice presentation. And we move to the second topic. We invite the second speaker, Imelda Emloho from Indonesia. Imelda will talk about the second topic, minimal hepatic encephalopathy, treat or not. Please.
Thank you, Mr. Chairman, for your kind introduction. So my talk, good morning, ladies and gentlemen. This morning I'm going to talk about minimal hepatic encephalopathy, whether we should treat or not. This is my disclosure. So this morning I will divide my presentation into two big parts. The first is definition and epidemiology of minimal hepatic encephalopathy, and the second is controversies in minimal hepatic encephalopathy. So as we know, encephalopathy is one of the complications of cirrhosis that results from liver insufficiency. According to the practice guidelines by the EASL and AASLD, it's defined as a brain dysfunction caused by liver insufficiency and or portal systemic shunting, and it manifests as a wide spectrum of neurological or psychiatric abnormalities. And the most important thing, it can be without any symptoms, and I mean subclinical, and progress until coma. So for hepatic encephalopathy that's symptomatic, the most common symptoms are confusion, disorientation, and poor coordination. These are easily recognized in clinical practice. So also according to these guidelines, we have to classify hepatic encephalopathy into according to four factors: underlying disease, severity of manifestations, time course, and existence of precipitating factors. So according to the underlying disease, there are three types. A, those result from acute liver failure, and B, predominantly from portal systemic bypass or shunting, and C, from cirrhosis. According to the severity of manifestations, we have two common criteria that we use routinely in clinical practice: the West Haven criteria, the first one, and second is the from the International Society of Hepatic Encephalopathy and Nitrogen Metabolism. We will go to this later. According to the time course, there is episodic hepatic encephalopathy, recurrent with bouts of hepatic encephalopathy with a time interval of 6 months or less, and persistent hepatic encephalopathy. And lastly, we have to look for the existence of precipitating factors. Is it non-precipitated, or is there any factors like infections, GI bleeding, diuretic overdose, electrolyte disorders, or any other comorbidities that may precipitate the hepatic encephalopathy. So originally, the West Haven criteria only divides patient according to normal and then 4 grades of hepatic encephalopathy. Grade 1 with sleep disturbance, euphoria or anxiety, or shortened attention of span. As it progresses, the patient will become lethargy, show inappropriate behavior, asterixis, or become disoriented to time and space. Furthermore, as it progresses more, the patient can become confused, somnolent, stupor, and then lastly coma. However, between the normal and the grade 1, there is a group of patients that is not symptomatic clinically, but they showed an abnormalities in psychometric tests, such as in working memory or visual spatial ability and cognitive performance. As well as there is also impairment in the electrophysiological and functional brain measurement. But the categorization between the minimal hepatic encephalopathy and grade 1 is often arbitrary, and the variety between one clinician to the others is great. So last in about 2011, the International Society of Hepatic Encephalopathy and Nitrogen Metabolism suggests a pragmatic categorization, which is unimpaired. It means that no normal psychometric tests, and then covered hepatic encephalopathy, which consists of minimal hepatic encephalopathy and grade 1 has hepatic encephalopathy, and then overt hepatic encephalopathy. So what is the difference between the covert and overt is the onset of asterixis. So when you have patients with asterixis, then you should categorize it as overt hepatic encephalopathy. So as we can see here, in the West Haven criteria, they some kind like quantitatively categorized this hepatic encephalopathy. But in the newer classification, hepatic encephalopathy is more like a spectrum of disease. So that we should remember that patient, this is a very subtle. I mean, the progress from unimpaired to covert and then overt is a spectrum of disease. So depending on the population studied and the diagnostic tool used, the incidence of minimal hepatic encephalopathy varies between 20% and 80%. And previously, the terms of minimal hepatic encephalopathy is subclinical, latent, or low grade, or early. But now we use minimal hepatic encephalopathy for this kind of patients. So once more, hepatic encephalopathy without symptoms on clinical or neurological examination is called minimal hepatic encephalopathy. But they still have deficits in some cognitive areas that can only be measured by neuropsychometric testing. So term minimal conveys that there is no clinical signs. So maybe the one who recognize that the patients have some kind like disturbance in attention or psychomotor skills or information processing is their family, the closest persons to the patients. So when they come to our practice, maybe we cannot recognize this kind of patients immediately. So I move to next part, controversies of minimal hepatic encephalopathy. So if it is not symptomatic, why is it so important? Apparently, minimal hepatic encephalopathy is associated with higher risk of developing overt hepatic encephalopathy, impaired health-related quality of life, and it is also a leading cause of cognitive dysfunction, higher burden of healthcare resources, higher risk of accidents and driving problems, higher prevalence of sleep disturbances, and higher risk of falls. The issues regarding the accident is largely studied in many studies, and Dr. Bajat's study has been published. This is one of the study that showed that real driving, hepatic encephalopathy is associated with the fitness to drive. So they include 51 cirrhotic subjects, 48 healthy controls, and all of the subjects do some real driving in a multiple sensor and camera equipped car, laboratory and in-car computer psychometry, and driving instructor assessment. In 10 cirrhotic patients, there is no hepatic encephalopathy, 27 patients minimal, and 14 patients overt hepatic encephalopathy grade 1. So in minimal and overt hepatic encephalopathy, patients showed significantly more violations of in-lane keeping, reduced brake use, prolonged reaction times, and diminished stress tolerance. So we see here that compared to the control or patients without hepatic encephalopathy, the reaction time of patients with minimal and overt hepatic encephalopathy is higher. Another study wants to know about the navigation skill impairment. So this is include 49 patients with cirrhosis and 34 patients with minimal hepatic encephalopathy and 15 without minimal hepatic encephalopathy. All patients underwent the psychometric battery and inhibitory control tests, driving simulation, which consists of training, driving, divided attention, and navigation. This is one of the results. So we see here that the number of illegal turns is higher in the minimal hepatic encephalopathy group. So patients with minimal hepatic encephalopathy have impaired complex navigation skills on a driving simulator, and this correlates with impairment in response, inhibition, and attention. This is another study about motor vehicle crashes. So the study aimed to determine the association of minimal hepatic encephalopathy with crashes and traffic violations over the preceding year and 1 year follow-up. So to determine, they use self and Department of Transportation reports to determine crashes and violations. So we see here that patients with the minimal hepatic encephalopathy diagnosed with ICT have a higher percentage of self-report crashes, and also report by the Department of Transportation. While all of the patients without minimal hepatic encephalopathy showed a lesser number of crashes. So this study concludes that patients with minimal hepatic encephalopathy diagnosed with ICT have a significantly higher rate of motor vehicle crashes. There are many studies on the effect of minimal hepatic encephalopathy to driving in the literature. So we have to really concern about this issue because unsafe driving will have an effect for others too. The next issue is the quality of life. So this is an old study from 1998. They study about whether subclinical hepatic encephalopathy have influence on patients' daily functioning using a questionnaire called Sickness Impact Profile. In this questionnaire, so the higher the SIP score, then the lower the quality of life. We see here that in all measures, on all scales, there are 12 scales here, the value of the SIP score is higher in patients with subclinical hepatic encephalopathy. This is another study from China. They did a multi-center cross-sectional study in hospitalized cirrhotic patients. They diagnosed the minimal hepatic encephalopathy using number connection test and one-digit symbol test. And they used modified questionnaire to assess the health-related quality of life. So the result is patients with minimal hepatic encephalopathy and higher child abuse scores were associated with higher health-related quality of life scores, so poorer quality of life. Minimal hepatic encephalopathy also have a higher risk to progress to overt hepatic encephalopathy and then coma due to the precipitating factors or spontaneously. Most of the minimal hepatic encephalopathy patients progress to overt due to the precipitating factors such as bleeding, dehydration, or sepsis. Minimal hepatic encephalopathy also associated with a higher cumulative and annual incidence rate of disease progression. So how to diagnose minimal hepatic encephalopathy? I just give a brief explanation here because there are so many tests and we will maybe need another session for this. So the problems of diagnosing minimal hepatic encephalopathy is that there is no standardized tool that can accommodate all patients with all ages and level of education. So, and most of minimal hepatic encephalopathy remains undiagnosed due to the lack of evident symptoms. Just like I said, maybe we have many patients in our clinics, so we don't even know them. I mean, especially those that come first for the first time to our clinics. We cannot readily diagnose or maybe have a suspicion that these patients have minimal hepatic encephalopathy. So there's an interesting study from the ASLD, from Dr. Bajaj's group, that surveyed 246 ASLD members. Most of them think that MHE is a significant problem, but as many as 38% never do a test for MHE. So when they ask for the reason, most of the responders feels that it takes a lot of time to do this test, and it's difficult and expensive. So it is a problem for us too. This is several kind of tests for MHE, from neurological examination, mini-mental state, psychometric hepatic encephalopathy score, and other psychometric tests like cognitive drug research battery, neurophysiological tests such as critical flicker frequency, and electroencephalogram. So this is mini-mental state examination. We usually use it to diagnose dementia, and an MMSE score less than 26 identifies older patients with cirrhosis who are more prone to manifest hepatic encephalopathy signs. This is a number connection test and other tests that is in the psychometric hepatic encephalopathy score. This is critical flicker frequency. I'm not going to go deeper on this. And the latest is Troop Test, an application that you can download it in your phone, in the Play Store or iStore. iPhone. And the recommendations now from the ESA-ISLD guidelines, the diagnosis and grading of MHE and covert hepatic encephalopathy can be made using several neurophysiological and psychometric tests. And it should be performed by experienced examiners. So what is the treatment? First of all, we have to control the precipitating factors. We have to search for gastrointestinal bleeding, excessive protein, hyperkalemia or hyponatremia, constipations, sedatives and tranquilizers, electrolyte imbalances, infections, trauma, dehydration, or uremia. And the aim of treatment is to control the precipitating factors and reduction of ammonia. There are some treatment regimens that are available, like non-absorbable disaccharides, antibiotics, L-ornithine, L-aspartate, and nutritional therapy or supplementation. New emerging treatments are prebiotics, probiotics, and symbiotics. So non-absorbable disaccharides such as lactulose and lactylol is the first-line therapy for overt hepatic encephalopathy. It is mechanism of action by reducing the synthesis and uptake of ammonia by lowering the pH of colon. All of studies, lactulose studies showed a good results and showed a significant improvement in psychometric tests. Antibiotics like rifaximin aims to reduce ammonia production in the gut, and rifaximin is chosen because it is minimally absorbed in the gut. The results are also good and can make significant improvement in psychometric tests. The prebiotics and probiotics resulted in increased fecal content of non-urease producing lactobacillus species and decreased E. coli and staphylococcal species in the gut. And the mechanism of actions is to decrease bacterial urease activity and pH in the gut lumen. So is it an alternative to lactulose? We have to still wait for a further study. This is one of the study using probiotic yogurt. And a significantly higher percentage of yogurt patients have reversal of minimal hepatic encephalopathy, and showed a significant improvement in number connection tests, block design tests, and digit symbol tests. So a significant rate of minimal hepatic encephalopathy reversal and excellent adherence in cirrhotics after probiotic yogurt supplementation is found. Another study of role of probiotics It's done in patients with HBV-induced liver cirrhosis in China.
Time to talk, 2 minutes more.
Okay. Thank you, Mr. Chairman. And this is the intestinal mucosal barrier will obviously improve after probiotic treatment. And for rifaximin and lactulose, there is no non-inferiority of rifaximin over lactulose. As in oral LOLA, apparently the result is not so good. Lately, there are studies about role of antioxidants and zinc in minimal hepatic encephalopathy, and the result is they can improve MHE in patients with liver cirrhosis. So the guidelines now say that treatment of MHE and covert is not routinely recommended apart from a case-by-case basis. So I think this is my several last slide. Who should be over treatment? So patients at risk of accidents, like active drivers, risk at work, or patients that complain of cognitive symptoms, like I have difficulty doing handwork, or I'm confused a lot, or I forget a lot. Patients with decline in work performance observed by relatives or colleagues, patients with progressive deterioration to prevent overt hepatic encephalopathy. So this is my summary. So we have to detect patients with risk of minimal hepatic encephalopathy to choose those that should be tested. And if they are unimpaired, we have to consider retesting in 6 months. If it's impaired on at least 2, then the patient has covered hepatic encephalopathy. So, Mr. Chairman and ladies and gentlemen, so burden of MHE is vast. So it is important on screening MHE in patients with end-stage liver disease. And the treatment will result in improvement in cognitive and psychomotor deficits and health-related quality of life. Thank you.
Thanks, Mr. Imelda. And ladies and gentlemen, we move to the third topic is we'll talk Jasmohan Bajaj from USA, Mr. Jasmohan from Virginia Commonwealth University Medical Center. Mr. Jasmohan will talk about the gut microbiota in liver cirrhosis, or not. Please.
Thank you. Thank you all. So the questions to be asked here are, why is it relevant to study microbial change in liver disease? Is cirrhosis actually a gut microbial disease? What is lacking in the therapies for cirrhosis that are focused on the microbiota? And what are the levels of therapy in reducing this severity? So before we go any further, let's talk about how microbiota are actually classified. These are the final genetic tree of life. In the green are the bacteria. In the eukaryotes are in the yellow, and archaea are in the purple. This is how all life is classified. Okay. The viruses are not here, and of late, archaea are considered to be a little bit closer to the bacteria as possible. So each and every line here represents diversity. These are the bacterial phyla that are usually present in the gut: actinobacteria, Firmicutes, Bacteroidetes, and Proteobacteria. Proteobacteria are usually the gram-negative rods, bugs that we love to hate. So in the eukaryotes, as opposed to the prokaryotes, bacteria and archaea are prokaryotes, which means single-celled organisms. Eukaryotes are multiple-celled organisms. So these are with fungi. Fungi are eukaryotes, but they're also a big part of our gut microbiota. And this is where all the animals belong. So look at how big the bacterial diversity is, and all the animals in the world are in this one clade. So it tells you that stuff in you, on you, and the stuff that you flush is way more complex than you actually will be. So it's very important for us to study the microbiota because they actually serve a lot of purposes. And if they do not serve you, they serve themselves, and bad things can happen to you. This is how a microbiologist will introduce E. coli to you. It's in phylum Proteobacteria, class Gamma Proteobacter, order Enterobacteriales, family Enterobacteriaceae, and species E. coli, and the genus is Escherichia. Below this, there are multiple strains. And it's important for us to realize that some studies stay at the phylum level, Some studies stay at the species level. Some studies are in the family level. So if you compare one study to the other and the level of taxonomy is different, there are thousands of members underneath every family. There are hundreds of members underneath each species. So you want to be very careful that you're comparing apples to apples when you're comparing studies. So ultimately, we want to know what these bugs are doing. What bugs are present. The easiest way, and that's what we use clinically, is use culture. But culture does not take care of most of the bacteria. So only the pathogens, because the culture, many of these bacteria are very fastidious. You have to make them grow for a little way. And then, so we can do the culture-independent techniques, which we take the prokaryotes has the ribosomal RNA 16S. The eukaryotes have 18S. So if you make primers only for 16S, you will only get prokaryotes. And then you can lump them together and find out what they are. The more important thing is what the microbes are actually doing. You can actually do this in many ways. You can actually see what genes are present, that is metagenomics. You can actually see what metabolites are being produced. The challenge with the metabolites is most metabolites are produced by the bugs or produced by the human beings or in the stool, or in the food and the stool. But there are very unique metabolites that are only produced by the microbiota, and our understanding of those are getting better and better and better. We want to ultimately close the loop. How does this affect the host? The host could be a mouse, a rat, a human being, groups of human beings, the entire population. Ultimately, we need to figure out, are these microbiota doing anything that can help our patients, harm our patients, or something that we can actually manipulate to make things better for them? So I'm using alcoholic liver disease as one of our things, and this is our review from Nature Reviews last year. And this tells you at what level does the gut-brain axis actually get involved in alcoholic liver disease. So you have patients with alcoholic misuse, right? There are so many people with alcohol misuse who never develop alcoholic liver disease. They only have some brain dysfunction. The brain dysfunction could be depression, anxiety, etc. And anywhere there's a star means the microbiota play a role. If they play a role when people with alcoholic liver disease develop alcohol, get alcohol, so of course they develop alcoholic liver disease. If they get steatosis to compensated cirrhosis, decompensated cirrhosis, alcoholic hepatitis, death, as well as hepatic encephalopathy. At all these layers of liver disease, microbiota may be important. But also more important than microbiota is stopping the underlying disease. So it is not enough for us to say, you can drink as much as you want as long as you drink yogurt with it. That is absolutely not true. Microbiota, as I'm going to tell you, go hand in hand. They make the effect of the alcohol or the hepatitis C or the NASH worse, but they don't cause the disease in the absence of the inciting organism. They are complicit, but they are not causative. So that's very important for us to realize. At all these levels, microbiota are involved, but they are not causative of this situation. And this is alcoholic liver disease. Similar things can be done for NASH as well. So it's important. So what happens before someone develops cirrhosis? Can you predict who gets alcoholic liver disease based on what their microbiota composition is? The answer is not really. These are healthy controls, and this is Bacteroideaceae. Bacteroideaceae is typically very good organisms that don't do anything. So their high presence means things are okay. These are people with alcohol who did not develop alcoholic liver disease, and these are the people who developed alcoholic liver disease but have no cirrhosis yet, not cirrhosis. And you can see there's kind of an overlap. So you can see there's a trend, but it's not causative. What about NASH? In NASH, the same thing. Follow the red. The greater the red is, the more the F1, F2, F3 goes further. But again, there's a big overlap. It tells you as the disease progresses, the microbiota get worse. But does that mean this is the chicken or the egg? What came first? Did the microbiota get bad first and then the liver disease happen? Or the liver disease has happened, therefore the microbiota got worse, because we have a very strict gut-liver axis. In human beings, you cannot do this because it takes decades for these diseases to develop. So therefore, we have animal models to do this. So in human beings, what are the differences in microbial composition between controls and healthy and patients with cirrhosis? There's differences in the stool. There's difference in the colonic mucosa, there's differences in the ascites, there's differences in the small bowel, and there's differences in the liver. The microbiota in all these areas is very different and potentially more harmful in patients with cirrhosis compared to healthy controls. Moreover, it's also different in the saliva, the serum, and the skin. Now, how does that happen? That happens because cirrhosis has immunodeficiency attached to it. Because there's an immunodeficiency, microbiota that would have had no business being in the skin, in the serum, in the saliva, now are suddenly there. If you look at people with cirrhosis and look at their mouths, they usually have a huge problem. They have periodontitis, they have a lot of issues going on, and that can be a big inflammatory load. And we're going to talk about that a little bit more. So this is a way you can actually quantify the quote-unquote goodness versus the badness of the bacteria. The good bacteria, which produce short-chain fatty acids and secondary bile acids, are on top. The bad bacteria are in the bottom. So if you have a ratio like this, a good ratio indicates everything is okay, right? Healthy controls, compensated, decompensated, and infected. So as patients go further along, the bacteria gets worse and worse. This is linked to change in outcomes. The microbiota in hepatic encephalopathy is much worse compared to those without, and this is linked to the colonic mucosa and brain function. Microbiota can also be used, as the previous speaker told. It's difficult to detect minimal hepatic encephalopathy, but we have now done studies in which you use the stool or salivary markers. If you find these bacteria present, it's highly unlikely that you're going to have minimal HE. So we are hoping to get a test in which you can just send the patient's saliva sample to a reference lab, and they can give you an answer within 2 to 3 days whether this patient has cognitive dysfunction or not. Microbiota can also predict who develops hospitalization in 90 days. Moreover, microbiota can also predict who lives or dies in the patient. So patients who have hepatic encephalopathy, you can predict who comes back with hepatic encephalopathy. You can predict who dies or lives, and in single-center studies here and in multiple-center studies here. It all begs the question, is cirrhosis a gut microbial disease? If you do the microbiota, if you just take microbiota associated with cirrhosis and you take them off or you put them back in a germ-free mouse, does it actually happen? So the first things first is hepatic encephalopathy. Do you need microbiota to cause brain inflammation? In this study, we had control mice who were made cirrhotics. These are conventional mice, basically exposed to all the bugs that you could possibly do. Then you have germ-free control, which are right here, and germ-free cirrhosis, which is right here. So the germ-free cirrhotic mice were made cirrhotic in the exact same way that the conventional mice were made. So now we're looking at IL-1 beta, MCP1, which are markers of inflammation, and then IBA and GFAP, which are marker of inflammatory glial activation as well as microglial activation. And you can see, despite the fourth group here having cirrhosis, the only group that has inflammation and microglial activation is the conventional cirrhotic mouse. So just having cirrhosis without microbiota does not lead to inflammation, which tells you it is all or none when it comes to hepatic encephalopathy in these mice. What if you give an alcoholic hepatitis donor microbiome bile acids into germ-free mice? Okay, this is the mouse. This is the microbiota from someone who did not have alcoholic hepatitis given into the mouse, and this is the microbiota of someone who had severe alcoholic hepatitis given into a mouse. And this is a principal component analysis. If the microbes are close together, they are related. If the microbes are far apart, they are unrelated. You can see the alcoholic hepatitis mouse, the mouse who got the feces from an alcoholic hepatitis person is very different from the other one. And this changed the bile acids also. So not only it changed the microbiota presence or absence, it also changed what the microbiota were doing. Remember, it's important for us not only to figure out what bugs are present, but also find out what bugs are doing. So in a patient with severe alcoholic hepatitis, it causes very different changes in the germ-free mouse compared to a patient who does not have alcoholic hepatitis. But that's not relevant because you can actually never fed them alcohol. So in our situation, we went one step further. We humanized a germ-free mouse with healthy controls, cirrhosis who were not drinking, and cirrhosis who were drinking. And then we sacrificed the mouse in day 30, and this is what we found. The bacterial translocation happened only in people who were actively drinking, mice who were actively drinking. These also had high serum endotoxin and high IL-1B. So the mice can actually figure out what microbiota are doing. So the microbiota are very different. So it's not like the germ-free mice, anytime you introduce a microbiota, they have the same response. The microbiota signature of healthy controls versus cirrhosis patients who are not drinking versus cirrhosis patients who are actively drinking is very different. And if you have cirrhosis plus alcohol intake, that is much worse than either of them alone. And I'm not going to go over the details, but this is the red are cirrhosis, and alcohol is right here. So if you look at the differences in the microbiota between the three groups, they're all very different from each other, and they cause change in the bile acids, the secondary bile acids, and activation of the enzymes of the liver that make the bile acids happen. So bile acids are one of the metabolites, especially secondary bile acids, that are only made by the microbiota. So there are good ways of actually following what happens. In this, the long story short is, the germ-free mice can actually differentiate between what the microbial constituents are. They adopt them as their own. They actually cause changes in the bile acid synthesis based on the microbiota. But, and here's the question, do these mice develop cirrhosis? No, they do not develop cirrhosis. They do not develop even a little bit of fibrosis in the liver. They get inflammation, but the amount of inflammation is a little bit. It's because these mice have not been exposed to microbes anytime, so anytime they see microbes, they get all excited. But the inflammation, it tends to be higher in those who were given cirrhotic and alcoholic mice, alcoholic stool, but it clearly does not lead to cirrhosis. So what it tells you that this is a problem, that you cannot rely on microbiota to be fixed to have your cirrhosis fixed. So here, systemic inflammation is present everywhere, liver inflammation a little bit. Cirrhosis will only be present. Severe alcoholic hepatitis mice who were given the stool from a person with severe alcoholic hepatitis, and mice who were given stool from someone without alcoholic hepatitis. If they are fed alcohol, the extent of alcohol-related injury is much, much higher in those who have the microbiota from someone with severe alcoholic hepatitis. But until and unless you give the alcohol, that is not going to cause the liver injury. So again, microbiota and the etiology go along together like a house on fire, synergistic. Alone, not so much in the mice at least. So hepatic encephalopathy, we talked about that it's important to have patients with the microbiota is important in germ-free mice. But what is the current therapy? The current therapy, rifaximin, is very good, but it's expensive, and not every person can tolerate this. What about VSL3 or other probiotics? It has good evidence, but at least in the United States, this is not good. This does not go through the FDA. So we have no idea what's in that microbiotic packet. So this has kind of faltered behind when it comes to that. And pathophysiology of hepatic encephalopathy really starts in the gut, because the liver is not behaving itself, the gut is not behaving itself. The liver gets hyperammonemic because the urea cycle doesn't work, and it gets more and more inflamed every time you see bacterial DNA. In addition, the kidneys become ammonia producers, and the skeletal muscle, as Dr. Reddy pointed out, does not do its job. There's not even enough of it, and the one that is present is not doing its job very well. Ultimately, it hits the brain in all sorts of ways. So how can we operationalize this? Can we actually diagnose cognitive dysfunction, as we briefly mentioned about? Can we do some dietary changes that can beneficially affect the microbiota? Or are there any newer therapeutic options based on the microbiota? So in this study, as the speaker before said, PHES, ICT, and Stroop, these are tests that actually figure out very different parts of the brain. And they don't really overlap with each other. So therefore, it is very difficult to standardize who has MHE and who is not. So we were trying to figure out, is there a way which we can actually figure out who does not have MHE? Because that's more important, right? Who is completely okay will not have problems with their brain function in the future. And what we did these 3 tests. We took stool and we took saliva of these patients. And what's very important, in a multivariable analysis, lacnospiraceae, which are good bugs, these are bugs that make short-chain fatty acids and secondary bile acids. And if you remember that ratio that I talked about, this was in the numerator. This was clearly in the numerator of that ratio. These were present in people who did not have MHE. It did not matter whether it was PHES, it was Stroop, or ICT. If you had these bugs present, your brain was functioning fine if you had cirrhosis. So this is a good negative predictive value. What about in the saliva? Saliva, we did not find a clear-cut thing of who did not, but we found a clear-cut way of who did. Streptococcus were much, much higher in people who had salivary, who had MHE on the saliva. And you can see we've already independently analyzed male gender, age, MELD score, prior overt hepatic encephalopathy, etc. All those clinical factors are already in this model. The microbiota now add to these clinical markers, and we are right now working on operationalizing it so that hopefully we can, at some point, we can send saliva off to a lab. It can tell you within 1 to 2 days what's happening, so you don't even need to worry about testing that patient in clinic, because all of these issues that come with logistics may actually be subverted. What about diet? We all know Mediterranean diet is very good. So we decided to do the analysis of patients from Turkey and patients from the United States. The United States follow a Western diet, very little probiotic foods. So this is the diversity. Compensated controls are in the orange, the compensated are in the green, and the decompensated are in the blue. And this is the USA, and this side is Turkey. So you remember the diversity means how many bugs that are present, different types. You ideally are supposed to have a very high diversity. A higher diversity indicates everything is okay. But what did we find here? That the Turkish controls, cirrhotic patients and decompensated patients had the same diversity, whereas the patients from America had lowering of the diversity as the disease progressed. Why did that happen? It's because people in Turkey drink fermented milk products every day. That actually keeps their diversity higher. And what's more important, it reduces their hospitalizations. When you looked at the 90-day hospitalizations in these patients, the Turkish people clearly had lower hospitalization than the American people, and this was independently associated with microbial diversity. So can we actually increase microbial diversity in our patient populations? Yes, eat yogurt. Eat a lot of yogurt. Not with the sugar, but the actual traditional yogurt. Those are very good. So, and important to realize, not all fermented foods are good, so beer is not really good for you. Yogurt is very good. I told you about the mouth. The saliva is pretty bad. So can we fix the teeth? The answer is yes. In groups of patients with cirrhosis who had mild to moderate periodontitis, not severe periodontitis and not normal. Why didn't we do severe? Because they cannot be fixed in one group. They need a lot of antibiotics and a lot of attention. And why not normal? If they're normal, what is there to fix, right? So we had healthy controls, and we had two groups of patients with cirrhosis. One group of patients with cirrhosis underwent dental cleaning through a dentist, dental hygienist, under supervision of the dentist. Not at home, but actually they scraped and everything, did everything. Then you had another group who did not do anything, and we followed them for 30 days. In the group that got the therapy, there was a reduction in the MELD score, reduction in the WBC count, reduction in the endotoxin, and reduction in the TNF. What's more, their salivary microbiota got better, their stool microbiota got better. In the patient in this group who had lactulose and rifaximin already on board, their brain function actually got better, which means the amount of inflammation that is coming from people's mouth that we tend to ignore is something that is a very low-hanging fruit. You can send those people to the dentist to get it cleaned. Nothing major, they can just get it cleaned. Moreover, the group of patients with cirrhosis who did not undergo this therapy had a worsening of the endotoxemia. Nothing got better, they actually got worse. So this is very easy for us to perform for our patients. Open the mouth, look at how bad things are, send them to a dentist, repeat every 6 months. What about fecal microbiota transplant? So in this group of patients in the United States, when they are lactulose and rifaximin, we really have nothing else to offer these patients. So we wanted to design a stool donor who basically had everything that was missing. So Lactnospiraceae and Ruminococcacea, which are the good bugs, which were in the numerator of that thing, were also present higher in patients who had who were cognitively intact. We took one stool sample from one donor who had this and give it to patient who had who are already on lactulose and rifaximin compared to standard of care. Our first thing was, is this safe? Because you know patients with cirrhosis have a problems in their intestinal barrier. We do not want to just shove all this stool up them and then actually end up causing SBP in these patients. The first thing, it was safe. Was it effective? Tended to be effective, but the N was very small, so we don't know. At least in this situation, there's improved in cognition. So here, the brain function improved in the FMT, which is in the green, compared to the standard of care, which is in the orange. The short-chain fatty acid production was restored because we gave them antibiotics before, and the bile acids also changed. So not only did the microbiota presence changed, the composition and the function and their effect on the brain change in these patients. What about when we use a capsule? In another trial, instead of using an enema, which is usually not acceptable to many people, we did a capsule, and this was placebo-controlled. And what we found, the hospitalizations went down in the capsule as well. The duodenal microbiota change improved. The serum lipopolysaccharide binding protein, which is the endotoxin binding protein, improved. And the secondary bile acid ratio improved. So what's important, out of the 10 people with cirrhosis who were randomized to FMT, 3 people did not do so well. And out of the 10 people randomized to placebo, 6 people did not do so well. We found that at week 4, if the people do not develop secondary bile acids, if they do not have secondary bile acids in their serum or their feces, this is not good engraftment, which means these people are not going to do very well. And what happens when you take these mice, these samples, and put them into germ-free mice? In the people who got the FMT material, they first got antibiotics. We put that into the mice, and then when they got the FMT, we put that in the mice as well. And the third thing that we did, we spun these microbiota, and we took only the supernatant to find out whether this was the actual microbiota itself or the function or the products made by this. And what we found is after these people, these mice, got the stool from someone who had received antibiotics in the red, in the bottom red, you can see the IL-1B, MCP1, which are inflammation in the brain, and IBA, which is microglial activation, is much higher. When you look at the greens, this goes down. So after antibiotics, there's a lot of brain inflammation because your microbiota are completely destroyed. Only the survivors, the resistant bugs are there. When you give the patient FMT, it gets better. And moreover, if you give germ-free supernatant, nothing happens. So the blue, the orange, and the purple are the germ-free supernatants and the germ-free controls. Nothing changes. So you need live bugs, and you need live bugs after FMT, which actually improves the brain function. So microbial changes are integral parts of the altered gut-liver axis. They're complicit but not causative of liver injury without injury itself. So if there's one thing you remember here, microbial treatment in liver disease has to be accompanied by treatment of the liver disease etiology. They have to go hand in hand. Current therapies can be improved. How? Regular dental cleaning and avoid periodontitis, withdraw unnecessary PPI use, carefully reevaluate the need of antibiotics, emphasis on fermented probiotic foods. Thank you so much.
All right, Jazz, thanks very much. If you were to come out here, and could I also ask Dr. Loho to come out? We'll have a few minutes for questions. Anyone has any questions, can you just come out to the mic and ask? Can you identify yourself? Yep.
Thank you, Irsan from Indonesia. I have a question for Professor Reddy and Prof. Bajaj. My first question, myostatin is a very important molecule to the incidence of sarcopenia, myostatin. And the high myostatin is triggered by increase of ammonia. My question is there any study assess the correlation between sarcopenia and the level of ammonia? So then we can predict sarcopenia based on the cutoff of the ammonia. And the second for Professor Bajaj, related to gut microbiota, there are two terms, small intestinal bacterial overgrowth and gut dysbiosis. Is there any relationship between these two terms? I mean, the small intestinal bacterial overgrowth, is that always correlated with gut dysbiosis? Is there any different treatment between these two conditions? Thank you.
So I'll address the first question. It's obviously an important one. Well, what we have to recognize is that ammonia is one factor in the pathogenesis of sarcopenia, while there are other factors. As we appreciate at baseline, ammonia itself, the determination has some challenges. It's something that is not reliably done because obviously we need to have arterial ammonia, it has to be sent right away. And so on, there's several factors that influence ammonia. So apart from ammonia, there is, which is a phenomenon of portosystemic shunting, there is this severe advanced liver disease that itself can, through pure intake or other mechanisms, portal hypertension, etc., can lead to sarcopenia. So I'm not aware of any study that has correlated ammonia with myostatin, and particularly given that it has it's a dynamic phenomenon, ammonia, I would think that it would be hard to correlate that with myostatin. So it's more of a theoretical, I guess, mechanism with some evidence that these patients do have increased myostatin levels, which obviously lead to perturbations in signaling of mTOR or mammalian target of rapamycin.
Thank you.
Thanks. Thanks for the question. So dysbiosis is a concept. Some people like it and some people don't. It means an unfavorable microbiota. But for you to know what unfavorable is, you need to know what favorable is. So we are still finding out from different parts of the world what works for some people and what doesn't work for some people. So dysbiosis is not necessarily just for the gut. You can have dysbiosis in the skin microbiota, the lung microbiota, the microbiota anywhere. So it's just a concept. Small bowel bacterial overgrowth is kind of, I would think, a little more outdated concept. It's before we knew this culture-independent thing, before we could only figure out how many bugs, count the bugs, and these bugs are higher versus lower. That doesn't mean that it's not there. It just tells you that you lose the whole picture. So there could be an overlap, but they're looking at two different ends of the spectrum. One of them is a functional analysis of bugs that may or may not be present. The second one is a presence of some bugs that are present versus the other. And there is no specific way of treating one to the other. Ultimately, you treat the patient. So for my thing is you treat the patient and see if things get better, and you focus on that.
Thank you.
Thanks. Question from there? Maybe you want to use this mic? Okay.
Yeah, thank you. Very nice presentation for both of speakers, Dr. Rajendra Reddy and Jas Rinaldi from Indonesia. I would like to ask Jas about the lecture you gave about the fungus. I mean, it's quite interesting that you mentioned about the fungi is, in fact, it's part of the gut microbiota. So because we know sometimes in daily practice, based on stool tests, sometimes we found also the fungus and the positivity in the stool test. Yeah. So do you think that, I mean, is it needed sometime to also give like the antifungus or just probiotic? Because I know in some patient when we give a probiotic, even the symptoms become better. Let's say like the bloating symptoms, sometimes the semi-liquid stool, and then but some patients they really need antifungus to improve their stool consistency. But I just want to know your opinion and how big the impact is the fungus positivity in the stool test related to the gut microbiota.
It's a very interesting question. What we have found, and others have also found in cirrhosis at least, the biggest determinant of who has fungus and fungal infections and fungal overgrowth or bad fungus, we all have fungus in our bug. That's how it works. We all have. So detecting that is not really an issue. The question is whether that fungus becomes pathogenic. And when does it become pathogenic? When you destroy the bacteria. Because the fungi cannot make their own food. they're dependent on the microbiota, on the bacterial microbiota. So if you give the antibiotics, unnecessary antibiotics, repeated antibiotics, those bacterial diversity collapses. Because the bacterial diversity collapses, the fungal diversity also collapses. So the only thing that remains is Candida. And you know that's the number one cause of most infections, not just albicans, the parasitosis and all the other stuff. So in that situation, we have to go back to why these people have fungus in the first place, or if you have a high suspicion that these people have fungal infection. I would not treat someone who just has a fungus in these places like skin or stool. If it's present in this ascitic fluid, it's present in the blood, that is clearly pathogenic. Those need to be treated because then you don't know when to stop. You start antibiotics, then you give stronger antibiotics, even stronger antibiotics and antifungals. You have nothing more left for the patient. So you have to have very, very strong reasons why you start any specific thing. And fungal colonization, which is what you're describing, or detection, is usually not enough. Again, go back to the patient and see what the patient is doing. Patient has renal insufficiency, is in the ICU. You know there's an infection, but you can never culture someone. That is the patient that's absolutely, you must start on antifungal treatment because the patient would die otherwise. But if the patient is an outpatient, there's nothing happening, little bloating here and there, and you find fungus in the stool, it's supposed to be there. It's, that's part of the thing, depending on how deeper you go down. If there's fungus in compartments that it's not supposed to be there, and the patient has a comparative, clinical profile, those are the only patients that we would end up treating. I don't know what your recommendation is and yours.
No, I think that's quite a reasonable way to approach. So, thanks. I had a question for Dr. Lowe as well as Jazz. So, minimal hepatic encephalopathy. So I have a struggle with it. So, sort of very interesting. According to Jazz's survey, 40% of the people who believe in this don't test. Could there be one other reason why they don't want to test? Because if I find minimal hepatic encephalopathy, am I supposed to take away their driver's license? What would you do? Because you pointed out that they're at risk for fender benders and other things. Now you diagnosed minimal hepatic encephalopathy. Are you liable if you don't take away the person's driver's license and the guy killed someone? So where do you stand, Jazz? Because I don't test because I don't want to diagnose it. Because if I diagnose it, I'm in trouble. I got to do something about it. So, what's your response?
Thank you, Professor Reddy. Yeah, it's very dramatic, right, about that. And I guess we should not decide it by ourselves as clinicians, but we have to communicate with the government about this issue. Whether what should we do with this kind of population? Should we take their driving license or not?
So in America, there's not a whole lot of support. The guy, if he does not drive to the shopping mall, he'll starve. So he has no choice. I mean, it's public transportation is not there readily, they got to drive.
Okay.
So what do you do?
So minimal HE alone, clear, read my lips, is not an indication for you to take anyone's driving license. There's no legal basis for that. 17% of MHE patients have accidents. 3% of regular people have accidents. That means 83% of MHE patients never will have an accident. So you can't do this draconian measure like close the borders, use masks, and do all the other things like for MHE. What you have to restrict is patients who have recently recovered from an overt HE endpoint. Those patients are the ones you clearly have legal liability. So 3 months after their HE. So MHE, absolutely none. But what it tells you, and what was clearly pointed out, is a marker of everything else collapsing in that patient's life. Driving is just one aspect. They can't do their job. They're not good, productive members of society. So that's why it's important to detect and give them a trial of treatment. We give them 8 weeks of lactulose. And after 8 weeks, if they feel better, we continue. If they feel better but they can't tolerate lactulose, we start them on rifaximin, if they want. Again, this is a case-by-case basis.
Okay, Jazz, if I get sued, I'll come to you as an expert. All right, well, on that note, we'll end this session, and thanks very much for being here. Thank you.
Cek, cek. Cek.
Sit, baterai udah diganti belum? Yang ini? Yang ini dua-duanya? Udah ya, takutnya mati. Nih, woi, habis. Habis. Cek, cek. Hehe, siap. Cek, cek.
minta ini dong, pensil. Mana dia? Gus. Udah, maksudnya kayak gitu. Anda cuma mau apa? Sudah empat. Pulang nggak?
Mana ini yang simpo yang mana? Aku sih nggak ngerti. Tuh, ini langsung ini. Yang simpo. Di situ nggak ada orangnya. Takut apa? Oh ini, yang ini nih. Saya kan ada itu bicara yang Fatty Pangras di sini juga ya? Itu juga. Nggak itu dari kursi. Malam. Kursi. Oh, dia bukan obstacle. Saya lihat kalau kemarin di programnya tulisannya kok Australia. Yang tadi udah? Ya itu.
Good afternoon, ladies and gentlemen, and my colleagues. We have already 10 minutes past the allotted starting time. Today's symposium is a very important symposium on the management of chronic hepatitis B, evolving concepts and practice essentials. Is sponsored by the Mylan Company. I'll be chairing together with Professor Renu Gani. He's still not yet around. And according to the program, the first speaker was Professor Cosmo Lesmana. Professor Lesmana, Dr. Lesmana got his PhD degree in 2012, and he became teaching staff as well as internal medicine GI consultant in the Medistra Hospital Jakarta and Medical Faculty University of Indonesia. And Dr. Lesmana will be presenting about the immunotolerant phase in chronic hepatitis B. Should we treat? A very important dilemma for us. Shall we welcome Professor Lesmana?
Yeah. Thank you very much, Mr. Chairman, Professor Win. Good afternoon, dear colleague, ladies and gentlemen. So, yeah, this afternoon I will deliver a talk about the immunotolerant phase on chronic hepatitis B. Should we treat? I think most of you is already familiar with the patient with hepatitis B infection. Also, I think during your daily practice, you will find that many patients may be also in the immunotolerant phase. However, there's some issues and maybe debate about this phase in our daily practice, whether we should treat or not to treat. Because we know that hepatitis B infection is one of the most cause also for the liver cancer. I think not only in Asian countries, but also in all over the world. So my outline of my talks will be the burden disease of hepatitis B worldwide, and then chronic hepatitis B infection, and the current treatment of chronic hepatitis B, immunotolerant phase of chronic hepatitis B, and the conclusion. So as we know that until now, maybe not in the whole world, in the whole country, but HBV infection is still a major problem, mainly in developing countries, including Indonesia. And we know that 25 to 40% patients will die because of the cirrhosis or the liver cancer. So all of us already know that chronic hepatitis B infection is the world's most common liver infection, where this infection has been considered as a silent infection, where it's often undetected for many years. Of course, in the country where the screening program is very good and people have a very highly educated, most of patients can be detected in the early stage of the disease. However, in such bigger country, and so kind of like Indonesia is one of the biggest in the Southeast Asian country, of course, it's not very easy to make a early detection of hepatitis B infection, because we know that like in Indonesia, there are so many islands. So to do the screening, early screening and the detection, sometimes not easy. And we know that in chronic hepatitis B infection, that the diagnosis and monitoring still are the key of importance in our clinical practice. So we look about the natural history of HBV infection. We know that sometimes it's not easy to find or to detect or to know whether our patient is whether in the immunotolerant phase, or maybe a patient in the chronic active hepatitis phase, or even maybe our patient is already in the early stage of the cirrhosis. Because most of doctor or in our clinical practice, usually we only use the transabdominal ultrasound to do the follow-up of our patient's liver. And we know that nowadays that the fatty liver disease also increasing. So sometimes not easy to make an analysis of the liver only by the transabdominal ultrasound if the patient also have the hepatic steatosis. So the prognostic state of the patient sometimes is very difficult to know where the patient come first to come to our clinic. And we know that most of our patients that will develop, also some of them will develop the decompensated liver cirrhosis. Some of them maybe they can have like acute liver failure or acute chronic liver failure and even the liver cancer. So this slide just want to remind us again about how the HBV life cycle, that until now there have been no really good drug to eliminate the cccDNA. So the problems with the HBV infection, that with the maternal transmission, it can be asymptomatic for many, many years. And of course, the undiagnosed, the HBV carriers, and then chronic hepatitis B infection with cirrhosis or cancer. And of course, the different phase at diagnosis, whether the patient with E antigen positive or E antigen negative. And of course, the last one is the different strategy of treatment. This one just to remind us again the phases of the chronic hepatitis B infection. Then you know that there are 4 stages of chronic hepatitis B infection. There's the immune tolerance, and then E antigen positive with chronic active hepatitis, and also the inactive carrier, and even the E antigen negative with the chronic active hepatitis. So 2 important phases is the E antigen positive with chronic active hepatitis and E antigen negative with chronic active hepatitis, which can progress to liver cirrhosis. So in our clinical practice, the common practice that we always do every day, so we usually evaluate patient whether it has a positive or surface antigen or negative, and then we want to see whether this patient include in the E antigen positive or E antigen negative. And there's still maybe some problem because of the cost also, that most of our patients, we need to evaluate their viral load examination, yeah, of course, and then the liver enzyme and also the abdominal ultrasound. So nowadays we know that many scoring and also the non-invasive assessment has been developed to do for the liver evaluation. Because we know that with the development of the hepatic steatosis and fatty liver disease, and even sometimes that not very high the liver enzyme, sometimes it's not easy to determine whether this patient has a chronic active hepatitis or not. So nowadays, most of center all over the world, even like in Asian countries, we start to use the fibroscan. However, even we use the fibroscan or transient elastography, so sometimes there are some factors also can be interfere with the result, such as the increase of the ALT level, jaundice, and sometimes very difficult in patient with ascites. So what about the current treatment of chronic hepatitis B? I know that treatment goals in chronic hepatitis B infection. So of course, the most important thing that how we can make the potent and the long-lasting the viral suppression. The most important goal is of course the seroconversion of the surface antigen. And then the long-term goals that we want to have to achieve is the prevention of the disease progressivity, so we can improve the survival rate of our patient. Improvement of liver histology appearance will be also the improvement of the quality of life of our patient. So we know that the prolonged treatment will induce the undetectable the DNA level, We then proceed to biochemical remission, histological improvement, and of course the prevention of the complication. So this just has also to show that where we used to learn as a medical student, as a resident, even the GI fellow, then when we have to treat the patient with hepatitis B infection, we know that the most important phase are the immune clearance phase and reactivation phase. And of course, we know that nowadays the treatment of choice for chronic hepatitis B infection is no longer with pegylated interferon, even though that we know that with the combination treatment, especially for such a young age, still possible to have a big impact to have the ACE antigen seroconversion. Nowadays, we use the oral antiviral treatment such as the entecavir, tenofovir, and also the new tenofovir generation, which can be very safe for the kidney problem. So what about the immune tolerant phase? We knew that in immune tolerant phase, of course, we have to first define that whether our patient is really in a chronic hepatitis B infection or not by the percent of the surface antigen more than 6 months, E antigen positive, and then high DNA level. And of course, usually the patient will have normal or minimally elevated of ALT or AST level, and sometimes we need the liver biopsy or maybe non-invasive test to confirm whether our patient showing no fibrosis or maybe just minimal inflammation. So this phase is more frequent and prolonged in subjects infected perinatally and is associated with the preserved HBV-specific T cell function, at least until the young adulthood. So this paper from our group, in fact, we have published this paper a long time ago in 2011, that we tried to see that most of our patient cohort in our university hospital, that many patients with chronic hepatitis B infection, but of course only the very less than twice upper limit normal with ALT level and high the DNA level. So as you can see here that some of these patients, they already developed the significant liver fibrosis. Even some of the patients also already developed the liver cirrhosis. So we know that the HBV integration and the clonal hepatitis expansion in chronic hepatitis B patient still can be considered as the immune tolerant phase. Yeah. So high level of DNA integration and clonal hepatocyte expansion suggesting that hepatocarcinogenesis could be already underway in this early phase of the infection. So this just to review some guidelines recommendation regarding the immune tolerant patient. As you can see from the EASL, ASLD, APASL, and even from the NIH and the US algorithm. So we can see here that in the EASL guideline is mentioned about the patient under 30 years of age with persistently normal ALT level, high DNA, no family history, liver biopsy. I think follow-up is mandatory. However, if we look in the ASLD, then of course also that need to be follow-up very tightly. And therapy is not recommended unless the liver histology showing that maybe the significant fibrosis. And of course in APASL also it has been concluded that patient with viral replication but persistently normal or minimally elevated ALT level should not be treated except patient with advanced fibrosis or cirrhosis. So immune tolerant patients need adequately follow up for HCC surveillance every 3 to 6 months. So this I just highlight to quote it from the APASL SBV guideline in 2015, I think there's been the changing between the previous guideline and the recent guideline. As you can see here that even the DNA level is not very high, and also the liver enzyme also not very high. However, despite the monitoring, but we have to assess the liver fibrosis. So if let's say that there's a specific or significant liver fibrosis and then moderate to severe inflammation, and especially there's a family history for a cirrhosis or liver cancer, treatment should be considered. And there have been published also from Korean group about the high risk of HCC and death in patients with immunotolerant phase chronic hepatitis B from a very large cohort patient, around almost 5,000 patients. Yeah. And then they divided to the immune tolerant phase, immune active, and mildly active. So the estimated cumulative incidence of HCC was 4.2% versus 1.6% at the 5 year in the immune tolerant phase versus the immune active phase. Yeah. And of course, the estimated cumulative incidence of death or transplantation in the immune tolerant phase versus the immune active group was 1.9% versus 0.8% at 5 years, and 9.7% versus 3.4% at 10 years. Yeah, so this is a slide to show you the graphic with the HCC and the death or transplantation group. So compared to the immune active group, major patient groups shows a significantly higher cumulative incidence of HCC with a high hazard ratio, 3.23. And of course, there's another study also when from the Korean group, when they compare between the chronic hepatitis B patient with untreated immune tolerant phase versus the dose with the virological response by the antiviral. So you can see here that the cumulative risks of HCC were similar between the two groups, yeah, and no statistically significant. Also, the cumulative risk of the liver transplantation group. So there's also no significant statistically difference of HCC compared between the two groups. So there have been publication about the effect of the tenofovir disoproxil fumarate in hepatitis B E antigen positive patient with normal level of aminotransferase and also the high level of SBV DNA. So this was a phase 2 randomized double-blind multi-center study with patients with high SBV DNA and the ALT level less than 2 times upper limit normals. So received the tenofovir, and all patients enrolled were HBV treatment naive. So this slide is to show that the tenofovir is combined. There's a 2 drugs combination and then one with placebo, and with almost similar the DNA level between the two groups. Yeah. So the proportion of patients who achieved the primary endpoint of DNA less than 69 IU per milliliter at week 192 were greater among patients with the combination treatment than among those only receiving the tenofovir alone. And the multi-center clinical trial comparing the tenofovir versus tenofovir and emtricitabine combination treatment for 4 years in 162 patients with immune tolerant phase revealed low virological response of E antigen seroconversion and 0% of S antigen seroclearance. So, dear ladies and gentlemen, Mr. Chairman, so my talk can conclude that chronic hepatitis B infection treatments is still challenging to cure. The current guidelines generally see the liver cirrhosis and ACC as a disease for which the prevention via antiviral treatment should only be considered after there is the clear evidence of the chronic active hepatitis. However, the hepatocarcinogenesis could be already underway in the immune-tolerant phase of chronic hepatitis B infection. And last, the initiation of antiviral treatment in immune-tolerant phase of chronic hepatitis B showed no difference cumulative risk than non-immune-tolerant phase of chronic hepatitis B infection. For that, I thank you very much.
Next speaker. Thank you very much, Dr. Rinaldi, for the excellent lecture. We will move to the next speaker, Professor Rosmawati Muhammad, with the title, Current Barriers to Hepatitis B Management, Asia Perspective. Professor Rosmawati Muhammad now is a consultant pathologist in University Malaya Medical Center. Yeah.
Thank you, Reno, and thank you very much for the invitation to speak at this symposium. So I'll start by showing you this global hepatitis B cascade of care according to the WHO regions of the world. And you can see clearly that in terms of HBs antigen positivity, it's highest amongst people in the Western Pacific and Southeast Asian region. So the Asia region bears the major disease burden related to hepatitis B. But more important is that you can see that this also reflects the large gaps in the hepatitis B cascade of care. And one of the things that we want to highlight is that amongst those who are infected, less than half are now considered treatment eligible according to the current recommendations by the three major guidelines. And you can see that even lower percent, 10% at most, have been diagnosed, and a tiny, weeny proportion of them actually are on antiviral treatment. So this large gap needs to be addressed. And then what I will do now is looking at the definition, or rather what is considered treatment eligible versus non-eligible candidates based on the current APASL, ASLD, and EASL recommendation. And I'll start by showing you this study from Korea, looking at the risk of HCC in patients who did not meet the hepatitis B treatment criteria based on the APASL, ASLD, and EASL. So this is a large study of patients who were monitored, more than 3,600 of them, without antiviral treatment because they did not meet the hepatitis B therapy criteria. And here on the right side, you can see in green the proportion of people who developed HCC were 64% according to APASL guidelines, 46% according to the ASLD guidelines, and 33.5% according to the EASL guidelines. And when you look at those with the highest incidence of HCC over 5 years, you can see clearly that those with cirrhosis but were not treated because they have low-level viremia had a cumulative risk of 14% of HCC. And the second group, the second highest group who developed HCC, are the non-cirrhotic patients. They have elevated DNA level, but only mildly elevated ALT. Perhaps this was the reason why they were not treated, and the incidence rate of HCC was 6.1 to 7.3%. So there's a very high proportion of them. And amongst those who were actually outside the treatment recommendation here, you can see that the factors, independent factors associated with HCC development were age, gender, the E antigen status, cirrhosis, ALT, and platelet count. So all these, we knew that these are the standard risk group that we see, except for perhaps the ALT being surprisingly also included. But you will see that studies have shown that these are some of the factors that make you have a higher risk to development of HCC. So what I want to highlight here is this substantial proportion of patients who are outside the treatment criteria, if you just base on this study alone, they may not be eligible for one, in cirrhotic group because they have low level of viremia, and the second group, the non-cirrhotic groups, because they had mildly elevated ALT. So perhaps the current criteria that's used is really unclear who are the eligible candidates for treatment. So let's look at the current treatment indications, first in the patients with cirrhosis. And in the WHO guidelines, it clearly stated or strongly recommend treatment for all patients with cirrhosis, either compensated or decompensated, regardless of the ALT level, the E antigen status, or the DNA level. Now, similarly, the EASL guidelines also say the same thing, that patients with cirrhosis should be treated at any level of DNA, regardless of ALT. And you can see here, high level of evidence with strong recommendation. However, the APASA guideline is slightly different because there is a DNA threshold to actually define who are the suitable candidates for treatment among patients with cirrhosis, depending on the type of cirrhosis. So for decompensated cirrhosis, treatment is indicated if there's any detectable DNA level. But patients with compensated cirrhosis, the 2015 guidelines state that you need to have DNA of more than 2,000 before considering those for treatment. So now let's switch to the treatment indications for patients without cirrhosis. And I think all of us are very familiar. There are some differences between the guidelines on the DNA threshold and the ALT level to define treatment candidacy. But what I would like to highlight is the lowest threshold, as you can see here, is on the far right by EASL, where the DNA level of 2,000 minimum and ALT of upper limit of normal indicates that you're suitable for treatment. And the reason being that the EASL guidelines acknowledge the possibility of having significant liver disease even in patients with low level of ALT. Now, there are some caveats from the AASLD guidelines. It reminds us that the level of DNA, the ALT, as well as liver fibrosis are all important predictors of long-term outcome. So they had this caveat that if your ALT is above upper limit of normal, but less than 2 times the upper limit of normal, then you should really consider assessing the liver disease severity either by biopsy or non-invasive testing, and you should look into other factors as well to consider treatment. Now, treatment is indicated if you have at least significant fibrosis, despite the ALT is not more than 2 times the upper limit of normal. So here you've seen the APASA guideline, the treatment indications in non-cirrhotic e-antigen positive patients. And you can see here that what APASA guidelines try to highlight is that if you do not have the DNA of more than 20,000, or if your ALT is less than 2 times the upper limit of normal here, then you need to do something further. You need to assess the fibrosis and then only decide whether treatment is indicated. So in general, it looks complicated, but it's telling the same thing. One is assess the viral load in these patients, or active viremia, and the second is assess either the ALT or the fibrosis. So similarly, in the e-antigen negative, the only difference is the threshold for DNA is lower, more than 2,000. And again, if you do not have the DNA threshold or the ALT more than 2 times the upper limit normal, then one should assess the fibrosis level. And again, you look at 2 things. One is the viral load, and one is either ALT or the fibrosis level. So in the EASL guidelines, it states that patients who are e-antigen positive or negative chronic hepatitis B, where chronic hepatitis B here is defined by DNA more than 2,000, ALT more than upper limb normal and or at least moderate liver inflammation or fibrosis, then these patients need to be treated. Now let's look at treatment eligibility based on the natural history of hepatitis B. And I'm not going to go through what Rinaldi has done, but just look at the current confusion on this treatment eligibility based on looking at the natural history, and mainly the name itself. So the new nomenclature of the chronic phase, as highlighted in the updated EASL guidelines, first divide patients with chronic hepatitis B into two groups, e-antigen positive and e-antigen negative. The second division is looking at the activity, and you can see here chronic hepatitis B infection or chronic HBV infection is differentiated from chronic hepatitis B based on the level of DNA, the ALT, and liver disease. And I think what I would like to highlight here is the confusion in the nomenclature itself. So in clinical practice, and we've heard earlier on, that we first assess patients who are S antigen positive with looking at the E antigen and the ALT, because that's cheaper. Some will be able to do the DNA, and that's a lot more expensive. But if you just look at something here in terms of the DNA, that all patients who are E antigen positive have a very high DNA level. They're usually at least 10 to the power 4. But in the E antigen positive, the first phase, chronic HBV infection or the immune tolerant phase, the DNA level is more than 10 to the 7. So in general, E antigen positivity has always been used in a resource-limited setting as a surrogate marker of having high viral load. So what I would like to show you is that sorry, I think I've gone too fast. So basically here, saying that liver disease is something which have only been really stressed in a hepatology or gastro specialist setting, but not so much in the primary care setting. And this is one of the things we should be stressing on, that staging of hepatic fibrosis is essential. So nowadays, we rely very much on non-invasive testing. And as mentioned, although transient elastography is actually reliable, is actually validated, but it's not widely available. So most of the time, we do need to stress the fact that we can use the serum biomarkers of APRI or FIT4 in most settings as a first-line test. And then you will assess further or refer these patients for transient elastography for places where that is available. So if you look at the natural history again of hepatitis B and look at where the treatment is actually recommended, it's recommended in this second and the fourth column, the so-called chronic hepatitis B patients, because they actually have got higher risk of disease progression, and that's why treatment is indicated. But what we would like to actually really understand is that for calling these patients chronic HBV or those without activity, you must really look further at the liver disease status. So this is the essential point that we need to actually look at to know or not whether treatment, the patient is treatment eligible or not. To simplify the indications for treatment, rather than just say it's using based on the nomenclature for the chronic phases, it should be based on the combination of the two main criteria. So in the EASL guidelines, it had this, the natural history and assessment of patients with chronic HBV infection, and one side is the HBV marker, and the second assessment is the liver disease activity. And that is depending on serum ALT and or level of fibrosis. So what we actually want to stress is not many people actually now do is there should be less reliance on the ALT level to define treatment candidacy. There should be a lot more lower threshold to actually assess the disease activity based on non-invasive markers. So let's simplify the management algorithm further to know who are the treatment eligible candidates. So this is actually the EASL algorithm. And again, the treatment is indicated in patients with chronic hepatitis B plus or minus cirrhosis, and the definition is shown here for chronic hepatitis B. But again, I would like to highlight to most non-hepatologists or non-specialists, chronic hepatitis B simply means having the virus or HBsAg present longer than 6 months. So if you can see the terminology itself, chronic HBV infection here means no signs of chronic hepatitis. And to create less confusion, it's possibly better to think about the treatment eligible candidates for those with disease activity, because we only think as doctors to treat when disease is present. So here, disease activity, again, is defined according to the fibrosis stage. If you are cirrhotic at any level of DNA would warrant treatment. For non-cirrhotics, treatment is indicated if the DNA is more than 2,000, ALT greater than upper limb normal, and or at least significant fibrosis. Okay, so the last part of my lecture is looking at addressing the large gap in diagnosis and treatment. I think this will be covered also by the others, but I just want to highlight this from the Western Pacific region point of view. And this is the hepatitis B cascade from the Western Pacific region, where it's estimated that 17% of people living with hepatitis B have been diagnosed, slightly higher compared to the rest of the world, but again, still small numbers. But here is what the gap is. You only see that only 4% received treatment in 2016, and even smaller number are virally suppressed, which is the current treatment goal for chronic hepatitis B. So what the Western Pacific has done is actually looked at what the priority actions with regards to hepatitis. And the first thing was actually highlighted because of the testing and treatment is not on track according to the latest data in 2018, is to really think about expansion of testing and treatment services. And to do this, you need to set clear target and strategy for testing, referral, and linkage to care and treatment. And the second thing that we need to actually do is that to actually really expand testing and treatment, we need to think of task shifting and simplified test and treat approach to make service available at the primary health care level. So the other thing that WHO WIPRO has also urged governments to do is call for political commitment, investment, and innovative approach to pushing the agenda of hepatitis elimination, and that includes the elimination of mother-to-child transmission of hepatitis B. So if you look at the EMTCT that is currently being proposed, this testing and treatment of pregnant mothers will occur outside the hospital setting. It will be at the primary care or maternity centers and will require decentralization and simplified approach. So before I end, I just want to share with you the proposed simplified test and treat algorithm for S-antigen positive pregnant mothers, which to start with first testing for HBs antigen in during the pregnancy, antenatal testing, and in the decentralized setting, rapid tests can be used, and there's even a rapid test for e-antigen at the moment, which is recently available. And the other simplification that you can think about is doing reflex testing. That means automatically test for e-antigen plus or minus DNA if the person is S-antigen positive. And the next step is looking at disease activity. And similarly, disease activity was defined as such, as mentioned before. But if you have no signs of disease activity in this S-antigen positive mothers, then you should consider treatment if they are either e-antigen positive or the DNA is greater than 200,000 IU per mil, and you start treatment, and the recommended is tenofovir at the 3rd trimester, and discontinue treatment either at birth or up to 1 to 3 months post-delivery, depending on what guidelines you choose to follow. And the last thing is that because of the risk of hepatitis B flare, it is also recommended to monitor the ALT 3 to 6 months post-delivery. So this is my last slide. To bridge the large gaps in the hepatitis B care cascade, will require addressing all the barriers in hepatitis B management, but particularly that related to treatment, eligibility, diagnosis, linkage to care, and treatment. Now, simplifying the hepatitis B treatment algorithm and even the nomenclature may address one of the most important barriers to treatment, which is identifying treatment-eligible candidates for now. So, second thing is about the to expand testing and treatment requires the decentralization, and this should be done through a public health approach, which includes task shifting, simplified test and treat approach, and use of rapid tests and reflex testing. And lastly, besides the health systems issues, the other barriers such as stigma and discrimination is poorly understood and also need to be addressed. With that, thank you.
Thank you very much, Professor Suswati Mohammed, for your very comprehensive presentation. There's a little change in the program. The next speaker is not Professor Ghani, but Professor Edward Gain, and Professor Ghani has gracefully agreed to let Professor Gain present in this place because Professor has to leave for the airport immediately after this presentation. So the Q&A for Professor Gain will be also immediately after his presentation. Professor Gain is the first person who started the liver unit in New Zealand, and he has developed hepatitis B community-based programs, and he is now chairing the sessions of the Ministry of Health Committee responsible for HCV elimination. And Professor Gain has been trained in the King's College. In fact, I don't need to introduce, everybody knows Professor Gain. Professor Gain, shall we welcome Professor Gain?
Thank you. Thank you, Professor Wynn, for your kind words. Dr. Ghani for letting me swap. Ladies and gentlemen, I'm delighted to be giving this lecture. And this, really what I'm talking about is what is practical in resource-limited settings, how we optimize diagnosis and initiation of treatment. And this is based on an Asian consensus, a series of meetings held over several years, chaired by myself or Mike Charlton from Chicago, with representatives shown here from over 25 different countries across our region, many of whom have either spoken in this session or are sitting in this room. And we feel we give a good embellishment of the entire region, including those resource-limited settings in low-income countries. These are my disclosures. A lot of the background data has been beautifully presented by the two previous speakers. Just to say, about 2/3 of the burden of hepatitis B is in the Asia-Pacific region, and across our region, the prevalence of hepatitis B infection is around 7%. But there is, as Rose showed, a huge gaps in the cascade of care. Only 9% of those people living with hepatitis B have undergone testing, and of those who have been diagnosed, only around 8% have initiated antiviral therapy. So this is really a poor reflection of how we're engaging the targeted population. Several regional studies in the Asia-Pacific have highlighted the lack of region-specific guidelines, so not EASL or ASLD or the PASL guidelines, but more focused towards local circumstances, in particular those countries which have a particular lack of resources or are unable to implement the current gold standard guidelines. So the question which has been raised already by the previous speakers, are the current published guidelines too conservative? We've heard, about this large Korean study, that patients who are E antigen negative infection, according to these guidelines, can have high HPV DNA titers and still have normal or near normal ALT levels, and these patients may still be at risk for the complications of liver cancer and progressing to decompensated cirrhosis. And we've heard about this study which showed clearly that those patients who had a high viral load and were E antigen negative had a significantly higher rate of both hepatocellular carcinoma and liver-related death or liver transplantation than in those who were started on treatment. So observing patients and not starting them on treatment appeared to be associated with an increased risk of complications. And results from these and many other studies we've already seen suggest that earlier initiation of antivirals before patients develop persistently elevated transaminases may prevent unnecessary deaths. This study, many of you would have seen, presented at the American Liver Meeting 2 years ago, is now in press, I think. And this was a randomized study performed in many sites where they looked at tenofovir versus placebo in patients with mildly elevated liver function tests, so less than 2 times upper limit of normal. And patients were randomized to either start tenofovir or to start a matched placebo. And you can see that those patients all had an HBV DNA in this study of more than 2,000, and cirrhotics were excluded. I guess the real importance of the study was that patients underwent paired biopsies at baseline and after 3 years in the study, either 3 years of placebo or tenofovir. And they presented the results for 132 of the total number who had had their 3-year biopsy, looking at the effects of treatment versus placebo on histological progression and on histological, both on fibrosis and necroinflammation. These are the baseline characteristics. Important to note that there were cirrhotics included in the study, slightly more cirrhotics in the placebo arm than in the tenofovir arm. Around a fifth of patients were E antigen positive, and the mean viral load was just above 3 logs. But patients had to have a viral load of 3 logs at screening, but it fluctuated above that. So these are the important key findings from the 3-year follow-up. As you'd expect, the patients on tenofovir had marked viral suppression and had marked improvement of liver function tests compared to those patients who were continued on placebo, even though the ALT elevations were mild in both groups. Inflammation was significantly less in the patients on tenofovir than those in placebo, and the most dramatic finding of the study was the prevention of progression of fibrosis in this so-called low-risk group by starting them on treatment. The proportion of patients who had a progression in fibrosis stage was twice as high in the placebo arm at 45% compared to 23% in the patients who were on tenofovir. And the proportion who progressed to cirrhosis, these were patients not cirrhotic, but who progressed to cirrhosis, was 4 times as high at 13.4% in the placebo arm versus 3% in the patients who received tenofovir. So we feel that there is scope to expand the current treatment guidelines to a more aggressive approach. And that reflects the issues in this region of very high endemicity across the Asia-Pacific, high rates of transmission, in particular from mother to child, high rates of progression to cirrhosis, and also high rates of hepatocellular carcinoma, reflecting certainly family history is a very important issue, poorly understood in the Asia and the Pacific regions, the risks of a carcinogen such as aflatoxin, high smoking rates, etc. And so we feel that countries in this region could benefit from a more aggressive approach involving advances in diagnostics and in the current antiviral therapies. And that timely management, early intervention of treatment may be of prime importance to prevent disease progression and save lives. So to get such an aggressive and simplified approach in our region, we'll need to scale up diagnosis and initiation of treatment in resource-limited settings to help. And I think this is absolutely imperative if we are going to go anywhere near meeting the WHO 2030 elimination targets for chronic hepatitis B. And hence this consensus document. And I'll a lot of this is well known to you, so I'll go through it pretty quickly. The diagnostic criteria, we've already heard from the two previous speakers, it's based on the finding of surface antigen is a marker of infection and maintained over 6 months of chronic infection. We all know how important it is to take a detailed history of patients, in particular of comorbidities, and in particular of a family history of either liver cancer or liver cirrhosis, as that increases the risk of that patient developing the same complications. And of course, the physical examination should not be forgotten, as it may pick up signs already of advanced liver disease. The pre-treatment assessments, this is not new to you. The usual blood tests, renal function is important, and we'll hear from the next speaker why it may become less so. We want full hepatitis B serology. It will be important, depending on which country we're in, to rule out various viral co-infections. Hepatitis A, in those countries where hepatitis A has low endemicity, I think vaccination is still strongly recommended. And ultrasonography is important both to determine advanced cirrhosis and if you are going to start surveillance for hepatocellular carcinoma. Assessment of the severity of liver disease after diagnosis is very important, in particular to determine whether or not the patient already has advanced fibrosis or cirrhosis. And we've heard how we've moved very rapidly in our region from liver biopsies, poorly tolerated, not accepted, to non-invasive markers of fibrosis. And the ones currently in use or widely used are the APRI, the FIB4 as serum markers, and the FibroScan transient elastography. And I've just given you there the cutoffs usually used for excluding cirrhosis or determining mild fibrosis. FibroScan is preferred, I think, as being the most accurate when it is available, but it often is not available. So APRI or FIB4 may be the only available choice. That is also preferred in those countries where FibroScan may not be as useful because of high rates of obesity, or when transient elastography is just not technically feasible because of patients having a flare and a very high ALT, or the patient may have ascites, although you'll know that patient has advanced disease. And I don't need to tell you in this room how you do regular surveillance for hepatocellular carcinoma with alpha-fetoprotein plus or minus ultrasound, depending on the patient's risk. So we'll just go through really what the consensus documents recommends in terms of starting treatment, monitoring people not on treatment, and who you can safely stop treatment on. So we've heard repeatedly the importance of HBV DNA levels in most of our patients, and I think that's the critical criteria for starting treatment. And if the patient has a DNA of more than 2,000, then further assessment is based on the ALT level. If the ALT is greater than the upper limit of normal, then antiviral therapy should be considered in that patient. If the ALT is less than the upper limit of normal, that is, it's normal, then we would suggest, extending on the EASL guidelines and beyond, that we should initiate antiviral therapy in the presence of any one of the following criteria. So a persistently elevated DNA above 2,000, the patient is older than 30 years, has at least moderate fibrosis, or has a family history, or has extrahepatic manifestations. What if the HBV DNA is low? That is, it's detectable by a sensitive assay, but less than 2,000. Well, you should consider antiviral therapy in the presence of one of the following criteria, regardless of the ALT levels. If the patient has a strong family history of cirrhosis or liver cancer, first-degree relative. What if the patient, if the HBV DNA is low and the ALT is elevated? Well, I think if the HBV DNA is very low or undetectable and the ALT is elevated, it's important to look further at other potential contributing causes for the abnormal liver function tests. And the things we think of every day, of course, are alcohol use, non-alcoholic steatohepatitis, other viral infections, etc. Patients who have cirrhosis, it doesn't matter whether they're compensated or decompensated. if the HBV DNA level is detectable, not less than 2,000 but detectable, then treatment should be initiated, and that's irrespective of the ALT or the E antigen status. There's good data to show that this will prevent decompensation in cirrhotic patients. And the consensus document summarizes these recommendations on starting treatment here, where we look at patients with a low HBV DNA level but detectable, and patients with a high HBV DNA level, and expanding the group of patients with a normal ALT about whom we might consider starting treatment on. And I've shown you patients with family history, above a certain age, or extrahepatic manifestations. We haven't recommended treatment for patients who do not have detectable HBV DNA, even in the presence of cirrhosis. What about those patients whom you don't start on treatment? How often should you monitor them, and how frequently should you monitor them? Well, the assessment of need to start treatment is based, as I've shown you, on the combination of ALT, DNA levels, and level of fibrosis as determined by non-invasive markers. And the frequency of monitoring depends on the risk that patient has of developing indications for antiviral therapy. And that would be highest in the untreated E antigen positive patient. And that patient should really have an ALT checked every 3 months, and HBV DNA and fibrosis stage checked at least annually, and HBV DNA probably every 6 to 12 months, and the antigen and fibrosis annually. What about the E antigen negative patient with a low viral load? Well, that patient, if they have persistently low viral load, their need for treatment in the absence of cirrhosis is going to be much lower. So those patients should have an ALT level checked every 6 to 12 months, and both the HBV DNA and the fibrosis severity checked every other year. An intermediate risk are those patients who are E antigen negative but who have a high HBV DNA level. And those patients really should have their ALT checked frequently. They're very likely to develop fluctuating ALT for the first year and then every 6 months, and then have both the HBV DNA level and the fibrosis severity calculated every other year. Who can you stop treatment? We usually think of nuke therapy as being lifelong therapy, but discontinuation of treatment can be considered in a few situations. Any HBV-infected patient who has a confirmed loss of surface antigen over 6 months can be considered for stopping antiviral therapy, even in the absence of anti-HBs. What about those patients who do not lose surface antigen? Well, we know in the E antigen positive patients, in the absence of cirrhosis, we do use E antigen seroconversion if maintained on consolidation therapy for at least 12 months, where that patient is maintained E antigen negative, E antibody positive with undetectable HBV DNA and normal ALT levels. These patients can be considered for stopping antiviral therapy in the absence of cirrhosis. But we know that the relapse rate can be significant, certainly in genotype C and in the older patient. So you need to do close post-treatment monitoring for relapse after stopping treatment following E antigen seroconversion if the patient remains surface antigen positive. What about in the patient who starts off as being E antigen negative before you start them on treatment, who does not have cirrhosis? Well, here there is some controversy. I think what is not controversial is stopping treatment in these patients if they achieve hepatitis B surface antigen, or if they achieve hepatitis B surface antigen loss even without surface antibody if it's maintained for at least 12 months consolidation treatment. So surface antigen loss, with or without surface antibody, is certainly an accepted indication for stopping treatment in E antigen negative patients. Now, you'll recall that the APASL guidelines have suggested that you could stop treatment if a patient has maintained on treatment undetectable HPV DNA levels at least 3 separate occasions, 6 months apart. It's very important to note that despite the emerging data from the STOP studies, that there is a high rate of reactivation. Some patients may have flares. People are looking at markers to try and predict the flares after stopping treatment in this group. There's no doubt that the longer the patient continues on consolidation treatment, that is, has undetectable HPV DNA on treatment, the more success rate of long-term suppression of treatment. But I think if you are going to stop treatment in these patients who haven't achieved surface antigen loss, you need to follow them very closely given the high rate of relapse. Surface antigen has been looked at a marker of predicting who's going to flare after you stop treatment, and people have looked at certain surface antigen levels at the time you stop treatment, certain cutoffs of 100 or lower. But considering the resource-constrained settings in Asia, quantitative surface antigen assays are not widely available, so we did not include the monitoring of surface antigen during treatment in these recommendations. And once you've stopped treatment, then as I've pointed out, it's very important to monitor people for the risk of relapse, especially the patients who remain surface antigen positive. So in those patients, DNA and ALT levels should be monitored closely for the first 3 months, and every 3 to 6 months thereafter or until relapse. And retreatment should be considered if the patient develops reactivation with persistently elevated ALT and detectable HPV DNA. Co-infections is very, for the co-infection recommendations in the consensus document, they're very much based on what is accepted in the EASL and ASLD guidelines. For patients with HIV and HPV co-infection, we're suggesting that you should use tenofovir disoproxil or alafenamide in your regimen for your antiretroviral therapy, and you should start treatment regardless of the CD4 count in the co-infected patient. I won't dwell on the Hep C co-infection rate, but this really follows the current guidelines where hepatitis C is presumed to be the dominant infection in most patients, and you do need to follow patients to look for evidence of HPV reactivation if you put patients on DAA therapy. And occasionally patients who meet the criteria for treatment for their hepatitis B, either at baseline or at the end of DAA therapy, should be started on appropriate nuke therapy for the hepatitis B co-infection, but that is the exception rather than the rule. Delta co-infection, the only recommended treatment in this consensus document is pegylated interferon for 48 weeks, and we know that that has very limited efficacy in terms of long-term delta RNA negativity post-treatment. Some patients with co-infection do have active HPV replication, and for those patients with active HPV replication, they should be considered for the usual treatment for their hepatitis B with nuke therapy. So really just to conclude, Chairman, ladies and gentlemen, looking at diagnosis and initiation of treatment in a resource-limited setting. Our region has intermediate to high HPV prevalence throughout the region. We have limited resources in many countries, lack of adherence to current guidelines, and many unmet needs in terms of diagnosis and initiation of treatment of hepatitis B. This current consensus guideline really considers the resource-limited settings we face and which many of us work in, and incorporates the recommendations from, as I pointed out, experts from almost 30 different countries in the region, which to provide what we hope is optimal guidance on the diagnosis and initiation of treatment, along with the management of patients with co-infection. We hope it will provide you with a simple algorithm for guiding the initiation, monitoring, and stopping of antiviral therapy in patients living with hepatitis B, and we hope it will guide clinical practice decisions and improve diagnosis and treatment rates and access to treatment in patients with hepatitis B throughout the Asia-Pacific region. This is a document. It's currently in press. It was published online at the end of last year, and I'd encourage you all to download a copy for free and to read it and to comment. Thank you.
Thank you very much, Prof. Gain. As I have stated earlier, Prof. Gain has to leave for the airport, so the Q&A for discussions for Prof. Edward Gain's presentation is open now. Professor Edward Gain will be ready to respond to your comments, query, questions.
Yes.
Julian Pribadi for Jakarta. Professor Gain, for E negative patient with cirrhosis, if we can achieve S antigen negative, can we consider to stop therapy?
I think in the real world, if a patient has surface antigen seroconversion, which is maintained, I think there is a risk that patients may relapse. Our guidelines were more for those patients who weren't cirrhotic. I think it's a modified risk, I think, about whether you stop treatment or not. We currently recommend stopping patients who don't have cirrhosis. Yep.
Thank you.
Very small risk.
Any more questions, queries, comments?
I think we're looking more, I think, in treating hepatitis B as an infectious disease and treating patients with active viremia and lowering the threshold for starting treatment if patients have active viremia.
Well, I would like to make a few comments, Prof.
Yes.
Kane. Speaking about Myanmar, my country, 80% of the people live in the rural area where they do not have safe drinking water, no electricity.
Yes.
So if we follow the guidelines, DNAs, the hepatitis B carriers in my country will never be treated. So Ministry of Health, including myself, and the WHO panel expert developed a more of treating cases as much as we can without requiring the DNA. And we mainly based upon the clinical guidelines, APRI, FIFO, because still it is a painful situation for my country for not being able to test for the DNA for the general population.
I think that's very important. None of the guidelines currently, even these guidelines, recommend treating patients based on surface antigen. But you're correct. I think it would be important to look at the benefit to the society as a whole. If you treated patients with very low-cost drugs, and you forfeited the need to do regular HPV DNA monitoring, because even the cheapest, most simple HPV DNA monitoring will far outweigh the cost of the treatment. So I think, you know, in the near future, I think we will see a study in a high endemic country where people will treat based on surface antigen and some other markers without relying on HPV DNA. I think it will mean that you will over-treat, that you will treat a lot of people who don't need treatment, but it may be indeed the most cost-effective way to approach the problem in some countries.
Yeah, it's also hard to test for the mother-to-child to prevent the mother-to-child transmissions, because we have to determine the HPV DNA before we are using the nucleoside analogs, tenofovir. can we just use this in setting of avoidance of mother-to-child transmissions? Can we give the patients the tenofovir? Because in Indonesia,
Yes. I think the data, and Roz showed beautiful data, the data is if you have a woman, a young woman who's E antigen positive, then that woman is very, very likely to have an HPV DNA above the threshold associated with mother-to-child transmission. And many, I think many studies have shown that almost all the women who need prophylaxis are E antigen positive. And I would have thought in that situation it is reasonable to consider treating on the basis of E antigen status. Do you agree, Rose? Yep.
Thank you very much, Professor Gain. Bon voyage. And shall we give Prof. Gain a big hand? The next speaker is my co-chair, Professor Rino Ghani. Professor Rino Ghani is the head of Hepatobiliary Division, Department of Internal Medicine, Faculty of Medicine, University of Indonesia. And Professor Ghani will be presenting about tenofovir alfenamide in the management of chronic hepatitis B. Time to switch. Professor Ghani, please.
Thank you, Professor Win. Ladies and gentlemen, dear colleague, my task today is to bring you the presentations with the title Tenofovir alafenamide in the management of chronic hepatitis B. Time to switch. This is the outline of my presentations. First, epidemiology and public health burden, new nomenclatures for chronic phases, the cumulative incidence of HBV resistant to nucleoside analogs, development of tenofovir therapy, the pharmacology of tenofovir alafenamide fumarate, treatment of E positive chronic hepatitis B, and also the E negative chronic hepatitis B, and conclusion. As we see that in our region, this is the region where 75% of hepatitis B, chronic hepatitis B patients live. And guidelines showed that the use of nucleoside analogs should be we should consider the HBV resistance. So the guidelines shows that the first line therapy for chronic hepatitis B treatment is with entecavir and tenofovir, because the rate of HBV resistance is very low. The tenofovir alafenamide fumarate, or TAF, tenofovir alafenamide is a prodrug of the tenofovir and was introduced as an alternative to tenofovir therapy to overcome the safety problems associated with tenofovir divoxyl therapy. You can see that the TAF, the molecule of TAF is more like the tenofovir divoxyl, but with the monoamide prodrugs. In development of tenofovir therapy, TDF is approved as a treatment for hepatitis B in 2001, and after that the tenofovir TDF is approved for HBV infections. In Indonesia, we have these drugs since 2012, and for 2016 we can use TAF as approved by the United States of FDA for chronic HBV infections. Pharmacology of tenofovir alafenamide showed that the TAF is more stable in plasma compared to TDF, and is also more efficient in entering hepatocytes compared to TDF. And so TAF can achieve higher level of tenofovir in hepatocytes compared to TDF. And because of the potent inhibitor for HBV replications at lower dose, these drugs have a more than 90% lower systemic concentration compared to tenofovir. So TAF appears to be improvement after TDF in terms of bone safety and also for renal or kidney safety. You can see that with the treatment for HBe positive chronic hepatitis B patients, the use of tenofovir alafenamide with only 25 milligrams compared to tenofovir divifoxil with more higher dose. In this case, the several parameters such as anti-HBe seroconversion, HBV DNA suppression, LT normalization, and also HBsAg loss can be comparable with the tenofovir divifoxils. This is the data that shows this is actually in dogs, but this data showed that the maximum concentrations of TAF is better in hepatocytes in day first and also in day 7 after the administrations of tenofovir alafenamide. So tenofovir alafenamide concentrations can be given in smaller doses to make it available for entering the hepatocytes. This also showed that tenofovir in plasma is less than tenofovir alafenamide in plasma is less than tenofovir divifoxil. So the systemic doses of tenofovir alafenamide is less than tenofovir divifoxils. Patients who receive tenofovir alafenamide 25 milligrams in this study showed that significant reduction in liver stiffness with FibroScan after 48 weeks compared to patients with tenofovir divifoxils. So in patients also in the patients with the E-positive HBV infections, tenofovir alafenamide shows non-inferior to tenofovir disoproxil fumarate and had improved bone and renal effects. In patients with E-negative chronic hepatitis B, tenofovir alafenamide compared to other nucleoside analogs, also with tenofovir diviproxil, showed that for HBV DNA suppressions, ELT normalization, and HBsAg loss can be comparable. Tenofovir alafenamide in the treatment of chronic hepatitis B showed that the treatment of these new, relatively new drugs comparable to the older drugs, tenofovir diviproxils. So there's no significant difference in the rate of HBV DNA suppressions between tenofovir alafenamide and tenofovir difiproxil. You can see here that the tenofovir alafenamide is better compared to tenofovir difiproxil for renal safety, because the eGFR changes in tenofovir difiproxil is less than tenofovir difiproxils. And also for the hip and bone and spine, for bone mineral density, the tenofovir alafenamide is the changes is better compared to the tenofovir difiproxils, either for E antigen positive or for E antigen negative groups. The concentrations of the tenofovir alafenamide for the serum creatinine level is also less compared to the tenofovir difiproxils in this study. So the patients who had received tenofovir alafenamide has a smaller reduction in creatinine clearance showed in this study. Our study in tenofovir difiproxil compared to terbinafine showed that in patients with TDF group, 68 patients, and compared to terbinafine, 62 patients, it showed that the patients with the tenofovir difiproxil group have more impaired renal function compared to the terbinafine group. So more patients have reduced renal functions in patients that use tenofovir difiproxils. And in this in our study, that tenofovir difiproxil may be should be considered for impaired renal function by using in patients with the tenofovir difiproxil treatment, and also in patients with eGFR less than 90. For bone mineral density, TAF versus TDF also showed better results with tenofovir alafenamide, either with the hip bone or spine bone for the mineral density. ALT normalizations in tenofovir alafenamide, the proportion of the normalizations of ALT is more than tenofovir disoproxil compared to the tenofovir alafenamide. So indications for selecting whether either to use entecavir or TAF over tenofovir disoproxil is in patients with age more than 60 years, or patients with bone disease using the chronic steroid or history of fragility or fracture or osteoporosis, and also patients with renal alterations that may be in patients with eGFR less than 60 or albuminuria 30 milligrams per 24 hour, low phosphate, and patients with hemodialysis. This kind of patients should be considered to have more safe drugs compared to tenofovir disoproxil. When to switch from entecavir or tenofovir alafenamide in patients with TDF, risk of development of under renal or bone disease. So, safety profile of tenofovir alafenamide showed that well tolerated in most of these patients, as we know that also in TDF. So in patients, the TAF is versus the TDF for HPV, the EGFR is more better in patients with TAF compared to TDF. Also in the hip and spine bone mineral density in the using TAF compared to TDF. Dear colleagues, my conclusion is the TAF is a promising new drug for the management of chronic hepatitis B, and tenofovir alafenamide or TAF was non-inferior to tenofovir disoproxil fumarate and had improved bone and renal effects. In patients with E antigen positive or negative, tenofovir alafenamide was also non-inferior to tenofovir disoproxil fumarate. Thank you for your attention.
Thank you very much, Professor Ghani. I'm sure there will be many queries or comments from the audience because this is a very important subject. However, the time is well past the allotted time, so I'm afraid to announce that this symposium is closed and over, and I would like to thank all the speakers and my co-chair, Professor Ghani. Thank you all. Thank you very much.
Okay, good afternoon, dear colleagues, ladies and gentlemen. Because we are running out of time, so we just move forward to the next symposium about the non-alcoholic fatty liver disease and other related problem. So here, I will chair together with Professor Jasmohan Bajaj from United States. He's coming back. So today, this afternoon, we will have 4 speakers. First one is Dr. Heri Jagat Purnomo about the update pathophysiology concept related to other metabolic parameters. And second one, Professor Jasmohan Bajaj about the role of gut dysbiosis and its impact on management. Third, Professor Chan Wah Keong, NAFLD and coronary arterial disease. And the last one, I will be talking about the NAFLD and non-alcoholic fatty pancreas disease. So I invite Dr. Heri Jagat to go to the stage, podium. So Dr. Heri Jagat is he is now the head of Division of Gastroenterology and Hepatology, Department of Internal Medicine, Dr. Karyadi Hospital, Medical Faculty, Diponegoro University, Semarang. And he is also a senior consultant and lecturer at Dr. Karyadi Hospital, Medical Faculty, Diponegoro University. So without any further delay, please, Dr. Heri, time is yours.
Thank you, Mr. Chairman. To be honored to be here for a speaker at the APASL 2020. My talk is update pathophysiology concept related to other metabolic parameter. My outline topic, natural history of NAFL, NAFL pathogenesis from time to time, update of NAFL and extrahepatic complication. As we know, natural history of NAFL, it's initially is a liver disease for metabolic manifestation in the liver and develop to type 2 diabetes, cardiovascular, simple steatosis for mostly patients, if stable disease, and not stable disease can develop to cirrhosis or HCC. And for NAS, 10% develop to fibrosis, cirrhosis, and decompensation and malignancy. Today, NAFL is a big problem because every time so high to high. This is the show of the prevalence of NAFL in the 4 countries in Europe, UK, Italy, Spain, and Netherlands, from more than 1,700,000 people adult diagnosed with the FIP form. For fibrosis, estimate 40%. It is the challenge for the problem for all, I think, from the region. The timeline of key development of non-alcoholic steatohepatitis, firstly, is by Ludwig. For the first call term, it's steatosis or nutmeg liver, and it's 1980. And time to time, link of NAS to insulin resistance with the complication, not only in the liver. Identification of the genetic predominant, like PNPL3 mutation with NAS, consent for abort from the another word. FLINE trial also, tonic trial, and PVEN trial. The firstly developed for 2 drugs, for can reduce and for release steatosis and histologic improvement in 2010. And after that, creation to accelerate drug development until now. But until now, FDA not approve again about this drug. Maybe to next year, 2020, maybe more, for the drug besides vitamin A and pioglitazone. In 2018 and 2009, first the pivotal NASH trial for 2 new drugs for to reduce and to regress the fibrosis or NASH. How about the novel pathogenesis from time to time? Firstly, pathogenesis, it's recognized as first two heads hypothesis and developed to novel to type 2 diabetes, and type 2 diabetes can develop to novel. It's a two hypothesis. And finally, I think not the finally, maybe it can progress because, but still now, three multiple head or organ crosstalk theory. It's the end of theory. Pathophysiology novel relate extrahepatic disease will give a better understanding of proper management, intervention, and prevention. First hit, it is start by overweight, insulin-resistant, and metabolic syndrome as the first hit. And accumulate free fatty acid is the product of metabolism. And lipogenesis de novo is increased. And second hit, it is role of stress oxidative make to the NASH result. It is a variation of the progress from normal liver, fatty liver, NASH, and cirrhosis, interaction about the insulin resistant, inflammatory cytokine, and oxidative stress. And 2015, the paradigm of NASH is metabolic syndrome manifestation in the liver still stop and change with the metabolic syndrome can develop from the NAFL, not NAFL from metabolic syndrome. It's mean it is can two direction, diabetes mellitus and non-alcoholic steatohepatitis. NAFL is associated with 2 until 3-fold increased risk for developing type 2 diabetes. Individuals with NAFL and type 2 are insulin resistant not only in the level of muscle, but liver, also in adipose tissue. Dysfunctional adipose tissue and increased rate of lipolysis contribute to ectopic fat accumulation, development of insulin resistance, lipotoxicity, and impaired beta cell function. This is the chart. It is kind of exciting for to understand about the mechanism. Insulin sensitivity until beta cell failure start and euglycemic start and the hypo and hyperglycemia in the end. This is the curve of insulin secretion and beta cell dysfunction interaction with the progression of non-alcoholic fatty liver disease role in the diabetes mellitus. This is also to describe the insulin resistance causes excess substrate like amino acid, glycerol, free fatty acid to the transport to the liver. And also, this is the role of relationship between adipose tissue insulin resistant and dysfunction and insulin resistant in the liver and muscle. Also, relationship between lipo and glucotoxicity, insulin resistant, and beta cell function. And finally, this is the multiple height hypothesis for the development of novel. The three organ, adipose tissue, liver, and gut, it's have important and significantly role for the pathogenesis from novel, NASH, etc. This is the multiple-head pathogenesis of novel and the role of genetic improvement. Genetic at this, the role have around 30% of all the patients with NAFL. Although obesity is strongly associated with hepatic steatosis, excess body fat accumulation is not only important factor of NAFL. Adipose tissue dysfunction is a key contributor to pathogenesis of NAFL. Genetic factor cooperate with metabolic and environment factor to promote the accumulation of fat and hepatocyte. Particularly, some patients will develop NAFL, but other will directly present inflammation and fibrosis, probably because of influence genetic and epigenetic factor. The next speaker will deeply about this topic, gut microbiome and pathogenesis of NAFL. May just brief that intestinal microbiota dysbiosis induced by alteration in diet may affect other hepatic lipid pathway, such as those improving bile acid metabolism, consequently increasing hepatic inflammation and fibrosis, and resulting in an increased risk of developing cirrhosis and HCC. This is the genetic susceptibility. It's understood by the theory for underlying pathophysiology of lean NAFL by maybe quite different. Genetic predisposition, fructose and cholesterol-rich diet, visceral adiposity, and dyslipidemia have potential roles in the pathogenetic underpinning. This is the old chart for describe role of genetic, particularly PNPL3 for commonality between the largest guide-wide association study in NAFL. The three largest studies are each designed a separate color with the first author name also given for clarifying. This is the genetic modifier of NAFL. It's divided for 4 steps: glucose metabolism and insulin resistance first step, second step the steatosis process, and second 3-step steatohepatitis and fibrosis. It's mean it is briefly for reduce or for increase de novo lipogenesis. It's the gain. It's mean it GGKR, and for free fatty acid increase and phosphatidylcholine metabolism in MPO87, and for inflammation and severity of NAFL PNPL3A, and also TM6SF2 for metabolism VLDL. This is the report of the meta-analysis study for PNPL3 susceptibility and severity of NAFL. PNPL3 RS73849 polymorphism and NAFL susceptibility. Also, this one of the describe association between PNPL3 and NAS. And also this one data for adiponectin level because of the metabolic parameter change in NAFLD. They study more than 2,000 subjects, also quantitative synthesized adiponectin or hypoadiponectinemia. This is in our center, single center case control study for the group with the NAS patient and non-NAS patient for metabolic parameter, syndrome metabolic, insulin resistant, TNF-alpha, and adiponectin. An association between N-terminal prototype natriuretic peptide and liver fat content, it's a new marker for development of the NAFLD. The protein is can analyzed by spectroscopy for NAFLD and the serum by cross-sectional study. the role of natriuretic pro-BNP protein. Multivariate linear regression show that this protein can be marker for the severity of progression of NAFL. Also, the like cytokine, another for TNF-alpha, interleukin-6 also can describe about the progression and severity of NAFL. How about the update for NAFL and extrahepatic complication as a main underlying for the metabolic parameter relate of complication another organ. As we know, NAFLD not only liver disease, but a multi-system disease. The pathophysiological effect of NAFL extend beyond the liver with a large body of clinical evidence and the magnitude of risk of developing this extrahepatic complication, underlying severity of NAFL. From psoriasis in the skin until type 2 diabetes, until cardiac, until malignancy and muscle or osteoporosis and another disease. This is the schematic to describe how to extramalignancy hepatic in colorectal cancer associated with the NAFLD. Pro-inflammatory mediator like TNF-alpha can make angiogenesis and increase cancer cell growth and proliferation secondary for hypoadiponectinemia and hyperinsulinemia. And how about for dysfunctional adipose tissue and the interaction between the non-alcoholic fatty liver disease can be directional to can develop of extrahepatic malignancy. And also, dysfunctional adipose tissue and non-alcoholic fatty liver disease can make develop to atherosclerosis and type 2 diabetes. That's why now by Leon Adam, NAFL leads to a broken heart. NAFL associated with adverse structural alteration and cardiac dysfunction. It has been proved by several meta-analyses. And the next speaker from Malaysia, Dr. Kong, will be present about this. This is a brief study in our hospital for the 64 outpatient with NAFL and how to correlation with the cardiac abnormality. Correlation between of non-alcoholic fatty liver disease fibrosis score and left ventricle mass index in NAFL patient. You can see that if the NAFL by NFS score severe, left ventricle index, it's more higher. And also, this means it is must to manage the NAFL very good to prevent cardiac abnormality. Also, this for the cardiac abnormality in the atherosclerosis measured by carotid intimal medial thickness in the 31 patient NAFL measured by ultrasound and carotid intimal medial thickness. You can see that NAFLSS can correlate it with the fibrosis and the degree of carotid intimal medial failure. Average carotid intimal medial failure according to NAFL fibrosis score, it is correlated. How about NAFL with the kidney? You can see that the gut, liver, kidney axis for this dysbiosis of the gut epithelium, if the maintenance for the barrier and NAFL as the produce of free fatty acid and the endotoxin from the system of the organ. And the renal can affect by lipogenesis and gluconeogenesis and uremic toxin and inflammatory cytokine. This is the meta-analysis of 9 observational study to increase predominantly Asian descent patients. NAFL on the risk of incident chronic kidney disease stage for 3 or higher. Also NAFL on the risk of incident chronic kidney disease by observational cohort study. Also this one brain. Is non-alcoholic fatty liver disease associated with structural brain measures? 2017, published in JAMA Neurological. The patient with NAFL, and we measure by MRI for the liver and the brain. For the patient with NAFL, reduce volume of the brain. It is important sign. And aging for 7 years. For all the patient, 4 years aging brain. It means brain involvement in NAFL. Liver steatosis can brain damage. This is the possible mechanism underlying the association between NAFL and cerebrovascular damage.
Sorry,
and
time is...
Yes, and I will give the conclusion. NAFL pathogenesis is complex and multifactorial. It is multi-system disease acting as an extrahepatic organ and regulatory pathway. 2 head hypothesis has been replaced by multiple head or crosstalk theory with an update of gut microbiome, brain involvement, and genetic predisposition. And improved knowledge of pathophysiological link between NAFL and this extrahepatic complication, we will have developed new pharmacologic treatment and decrease the global burden of this very common non-communicable disease. Thank you so much.
Thank you for your very nice comprehensive lecture, Dr. Harry. So the discussion after all the speakers. So the next, it is my honor, great honor to invite Professor Jasmohan Bajaj from United States. He's a professor in medicine and also the senior consultant at the Virginia Commonwealth University Medical Center. He will therefore talk about the role of gut dysbiosis and its impact on management. Please, Dr. Bajaj.
Thank you. Thank you all. So a lot of this is repetition. If you hear for the cirrhosis one, just let your brain go blank a little bit. So we are going to talk about, as the first speaker presented, very nice data on the gut microbiome and how it interacts with the cirrhosis, with NAFLD as well. So gut-liver axis changes before and after cirrhosis. What happens longitudinally in NAFLD, and what therapies can be used? Prebiotics, probiotics, gastric bypass, and fecal microbiota transplant. The last two, the gastric bypass and fecal microbiota transplant, I'm not going to talk about in detail, and FMT, there's very little studies right now anyway. So this is the altered gut-liver axis. You know, there's a lot of stuff happening here. Antibiotics, prebiotics, probiotics, fecal transplant, etc. This is intraluminal. And then there's the epithelial barrier. A whole lot of other things happen in the epithelial barrier. And every time you see multiple processes, it means that it's such a complex procedure that we absolutely have no idea what the hell is going on at that particular moment. Because the gut microbiota is so variable. Anytime you change your diet, it changes. Anytime you go to a different environment, it changes. It's a reactive organ. So when we're talking about NAFLD as something that affects all organs, the microbiome is a living, breathing, reacting organ, and we have to think of it that way. So then you come to the portal venous circulation and the gut vascular barrier. We often think that the gut barrier is just a physical barrier. It's not just a physical barrier with a tight junction, it's also an active immunological and vascular barrier. So there have been nice studies done in which the gut vascular barrier is shown to be as potent as the blood-brain barrier. So that's why we don't get infections with all these large bacteria all the times. In addition, there are lamina propria lymphocytes as well as other immune cells that make sure that any pathogens that make it through are actually figured out. Then it goes through the portovenous circulation and finally into the liver. In the liver, it can have effects on the target cells, including the hepatic cells, and that's what the theory is. And this is where the problem comes with the microbiota. There are so many things that can affect it. Active alcohol, antibiotics, comorbid conditions, medicines, diet, organ failures, host genetic, liver disease etiology, and liver disease stage. And who here knows a patient who's purely NASH? There's hardly a patient who's purely NASH or purely alcohol or purely hepatitis B or purely hepatitis C. So there are people who have combinations of all diseases with multiple genetic factors, multiple dietary histories, which makes it very hard for us to conclude that this kind of microbiome will result in NASH. And this kind of microbiome will be protective against NASH. Each patient is his or her own person. And that's why you have to figure out what's going on with that person if you want to use the microbiome as a target for diagnosing, prognosticating, or treating NASH. So what happens in the pre-cirrhotic stages of NAFLD? Here are the people with NAFLD and people without NAFLD. These are the stool microbial families. And you can see things such as Lactobacilliaceae and Lactospiraceae and Ruminococcaceae, which are good families, good bugs, are actually lower in the stool microbiota of NAFLD. What about in this other study, Bacteroidetes to total bacteria ratio? Bacteroidetes are pretty harmless kind of microbiota. So if there are higher of them compared to the whole ratio, it tends to be good. So you look at the healthy controls, look at the simple steatosis in the middle, and the NASH. NASH has the lowest amount of Bacteroidetes in total ratio. And on the right side, you see in yet another study, Enterobacteriaceae, especially Escherichia, E. coli. Those are much higher in NASH compared to normal and obese people. This is pre-cirrhotic NASH. This is not cirrhotic NASH, okay? What happens when you actually get even further? On your left-hand side, you have NASH with and without fibrosis, and then you have ruminococcus, and this is fibrosis more than stage 2 up top. In the bottom, if you follow the red bars, that goes higher from F1 to F2. Again, this is a cross-sectional study, so you don't know if the microbiota changes happened before or the liver changes happened before. All we know is they grow hand in hand. If you have worse liver disease, you have worse microbiota, but you don't know what caused what. And this thing remains after NAFLD, after development of cirrhosis. On your left-hand side and the right side, there's differences in alcoholic cirrhosis and non-alcoholic cirrhosis. You can see even after the development of cirrhosis, the microbial profile in people with NASH-associated cirrhosis is very different from those with alcohol-associated cirrhosis. Alcohol-associated cirrhosis has much more dysbiosis compared to NASH even in that situation. Of course, we know about this very rare case that we are fascinated by. Do the bacteria itself produce ethanol? This was first actually found out in an animal model by Anna Maydiel, and it was very hard for her to get this published because no one believed that the microbiota could actually produce alcohol. And of course, the mice don't go to a bar. They are there. So if there's alcohol in their system, it has come from something that we provided. And if we provided a diet that was obesogenic and they had exhaled alcohol, that means the diet was producing alcohol. Then there was a pediatric study. Pediatric study showed that gram-negative organisms belonging to Enterobacteriaceae clearly produced alcohol. And the children don't go to the bars, so they actually were fairly confident. And then this very dramatic case from China in which they found that this Klebsiella pneumoniae, another Enterobacteriaceae component, was able to produce so much alcohol in a person who was not drinking that was actually going to actually make NAFLD, so to speak. So this is called the autobrewery syndrome, but this is very, very, very rare. In most people, if you detect alcohol, they have been drinking, unfortunately. So NASH versus ASH becomes now MASH, You've heard of that new term, I'm sure other people are going to talk about. So can we use the stool and blood microbiota to predict who has NAFLD? Because with ELF and all the other tests, it's still a little difficult. So the more pieces of evidence we have joining together, it's easier. So if you have a FibroScan is expensive, you know. Of course, stool microbiota is also very expensive right now, but hopefully with time, as more and more people start doing it, it'll become cheaper. So the more things that we have to see if someone has advanced liver disease or not in the general population, the better off. So in this small study, they found that NAFLD and advanced fibrosis on the left side, again, higher proteobacteria, the gram-negative rods, E. coli. This was which found that the AUC was 0.936 in a very small study. What happened to the blood microbiota? In another study, the copies in the serum in people with NASH and F2 or higher fibrosis was much higher, and the diversity was lower. So what does that tell you? If the copies are higher but the diversity is lower, that means the same type of bug is there, but not enough of the other bugs are there. So the same 1 or 2 types of bugs make it the way across the intestinal barrier, are there in the serum microbiota, and can potentially be used to actually detect NAFLD. However, we need larger and multi-center study to increase the uptake of this methodology, because you remember that big circle, 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 so many things can affect the microbiota. These are all single center studies. That one is from France, this one is from San Diego. So it may not necessarily be applicable to other places. What about things that the bacteria actually make? Secondary bile acids or fecal bile acids. In NAFLD, and I'm going to spare you the trouble, in NAFLD compared to controls, there were higher total serum bile acids, higher primary bile acids, and lower secondary bile acids. Why is this important? Secondary bile acid formation means there are good bacteria present. Primary bile acids converted to secondary bile acids by very few bacteria, such as Lactospirus and Ruminococcacea. That means that the bad bacteria are higher, the good bacteria are lower. However, is this specific for NAFLD? No. This is for any disease process in which the fibrosis gets worse. As the fibrosis gets worse, the primary bile acids remain high, the secondary bile acids remain lower. So it really needs a lot more work right now to figure out whether this is specific to NASH or if this is just a way of the fibrosis of the liver to getting worse. So now we talked about cross-sectional studies in microbiota in NAFLD. There was changes in the stool microbiota, there were changes in the serum microbiota that correlated with and without cirrhosis in these patients. What happens when you follow the patients longitudinally? So in this nice study done by Dr. Wong, they actually did the intrahepatic triglyceride content and the fecal bacterial abundance. And you can see after NASH resolution, there was lower intrahepatic triglycerides, higher bacteroidetes, and lower firmicutes. What it tells you, as the liver, if you do something with the patient and the patient loses weight, that can also be reflected in the entire gut-liver axis. Again, this intervention or this follow-up was not based on a gut-related issue. It was based on just following. So it just tells you that that relationship is intact. The gut-liver axis is also intact. What happens when you give people a choline-deficient diet? You know, in mice, you give them a choline-deficient diet, it actually causes mice to develop NAFLD. In humans, it becomes very difficult. In this nice study, they basically trapped people into getting a choline-deficient diet, and they found that these patients developed NASH. And not only did they develop NASH, gamma proteobacteria, which again, it all comes back to the same group of bacteria, E. coli, Klebsiella, they all belong to gamma proteobacteria. They got higher as the people developed choline deficiency-induced fatty liver disease. So now comes to the large question. Can we actually manipulate the microbiota to make things better for our patients? Let's talk about pre, pro, syn, and postbiotics and NASH. So what are all these things? A prebiotic is a substrate that is selectively utilized by host microorganisms, conferring a health benefit. It is not an alive substance. Probiotic is a live microorganism that, when administered in adequate amounts, confer a health benefit. A synbiotic is when you have a prebiotic and probiotic together. And postbiotic are non-viable bacterial products or metabolic byproducts from probiotic microorganisms that have biological activity. such as things such as polysaccharides, enzymes, cell surface proteins, organic acids, short-chain fatty acids, etc. So this is pre, pro, syn, and postbiotics. Now let's see what the evidence is with probiotics and NASH. The largest study is 6 months with N of 20. Not very good. Obviously, the larger the duration of the study, the smaller the sample size, because this is a huge population and it becomes difficult to follow. What about prebiotics? Very small number of studies. And what about symbiotics? Similar trends, but some of the studies here are for a little longer duration. 24 weeks is 6 months, 28 weeks and 28 weeks. But again, very inconclusive. And putting all these together, prebiotics, probiotics, they're not the same thing. Each bug has its own stamp on the microbiota. So it's like combining, an antituberculous drug and saying that it is the same as cephalosporins. It's not the same thing. They affect the microbiome in a very different way. So if you were to design a study with probiotics or prebiotics right now, how would you go about doing it? Non-cirrhosis NASH therapy outlines per the FDA. An early phase 2 requires histology with the proof of concept. If histology does not change, there's no point going forward. In the late phase 2, 12 to 18 months with histological changes and biomarkers. So what would be an ideal probiotic or microbiota study? You want to have defined strains, not just random probiotics thrown together, with minimal variations in colony-forming units per dose. Engraftment would be localized and systemic actions would be known. So you need to know how much of that probiotic stayed in the system, how much was excreted, and what effect did it have. What was the change in microbiota composition and function? And the other organisms need to be recovered from stool intact as a marker of the patient was taking it, and also that it was not destroyed. And there has to be a clinically relevant outcome, not just intrahepatic triglycerides. It has to be something important like histology. So what happens when you give someone fecal transplant? Okay. In this study was even more expansive. They did it in people with insulin resistance. It was not necessarily for NAFLD. And what they found, they divided people into people who got a donor and people who got their own stool back, autologous FMT. And in the small study, they found that there was actually encouragingly an improvement in insulin sensitivity. So insulin resistance went down with the donor FMT, but not with the autologous FMT. However, when they expanded it to larger duration, it did not work. So it's really disappointing because this is the most radical shift you can possibly think of the microbiota. But it's also tells you that, again, it's not just the microbiota. The microbiota is one part of the entire puzzle that is happening in these patients. So what are the summary treatments that target the microbiome? They're not really convincing. Prebiotic, moderate reductions in serum aminotransferases. Probiotics, small reductions again in serum AST and ALT. Symbiotics, no reduction at all. Antibiotics, short-term studies. FMT, there have been small studies that are going on, and right now there's one that we just accepted in the Red Journal, which was a negative study, a purely negative study. Good powered study from Canada, no effect at all. Obeticholic acid, we know, is very good, but the effect on the microbiome right now needs to be figured out. It may just be a direct effect on the FXR, and the other two FXR agonists, the microbiome effect is not studied just yet. And where is the problem? The problem is this. NAFLD is a huge, you have fatty liver, you have stable cirrhosis, and this is, people have done studies for little bit here. What you need is a study that goes on for years. If you look at all the pharma trials that have been done right now, or are in the process of being done, they last for years. So you can't have a microbial study which is 6 months maximum and expect a lasting change in someone who does this. So that's the problem right now with the amount of microbiota studies that have been done in NAFLD, and that's a problem. And more often, we need to go beyond association. Right now, we are currently in the association phase for such an important disease for our population in every part of the world. This is something that we need to get our act together. So in summary, NASH is a multifaceted disorder which is associated with an altered gut-liver axis. Bile acid perturbations and microbiota compositional changes worsen over the course of fibrosis severity with more extreme changes towards cirrhosis. Treatments for NASH are increasingly focused on the gut-liver axis with modulation of bile acids, including obeticholic acid and other FXR agonists. At this time, there is inconclusive evidence that using pre, pro, or symbiotics can improve NASH from a regulatory standpoint, although there's enough proof of concept. FMT are undergoing, but they're not conclusive, and I can tell you that one failed. Gut microbiota changes will likely be part and parcel of an overall strategy to treat the metabolic syndrome. Thank you so much.
Thank you very much for your very nice lecture, Professor Jasmine Bajaj. So I will let Prof. Jas to introduce the next speaker.
Thank you. The next speaker is Dr. Janba Kyong from University of Malaya, who's going to talk to us about NAFLD and coronary artery disease.
Thank you very much, Mr. Chairperson, for the kind introduction. Very good afternoon, ladies and gentlemen. First of all, I'd like to thank the organizing committee for inviting me to give this talk today. It's really a pleasure to be here. So the title that has been given to me is NAFLD and coronary artery disease. Can I have the slides on the screen, please?
I think they want you to wait till the entire 2 minutes. They're not used to people finishing early. I finished 5 minutes early. Please, we're already late. Bring his slides up, please.
Okay, maybe I can do it from here. Let me just try.
Can you? No, don't. I think he's running.
Okay. So I'd like to thank Dr. Harry earlier because he actually covered the pathogenesis, which I will not be covering during my talk on NAFLD and coronary artery disease. I will also not talk about cardiomyopathy or cardiac arrhythmia. I'll just focus on coronary artery disease, as this is the title that has been given to me. So we know NAFLD encompasses a spectrum of liver condition that's characterized by excess accumulation of fat in the liver. And we know that it's related to chronic overnutrition. And NAFLD is closely associated with obesity and is considered the liver manifestation of the metabolic syndrome. So, and we know the metabolic syndrome is actually a constellation of risk factors for cardiovascular disease, and is defined by the presence of at least 3 out of 5 criteria, which include central obesity, hypertriglyceridemia, low HDL cholesterol, hypertension, as well as abnormal glucose profile. And we know that NASH is actually the more severe form of NAFLD that's defined histologically by the presence of hepatocyte ballooning as well as lobular inflammation. And it's patients with NASH that tends to develop fibrosis and cirrhosis. NASH patients, especially with the presence of advanced fibrosis, are those who are at increased risk of getting liver-related complication and mortality. Right. So, yes, as mentioned earlier, what fatty liver is the liver manifestation of the metabolic syndrome. And this is what I've been talking about, that NASH is the more severe form of NAFLD. And patients with NASH, especially when there's advanced fibrosis, are those who are at increased risk of liver-related complications and mortality. And across this entire spectrum, patients with NAFLD are at increased risk of cardiovascular disease. And in fact, cardiovascular disease is the leading cause of mortality in NAFLD patients. So there have been many studies on the association of NAFLD and coronary artery disease. I'll be presenting a meta-analysis of these studies over the next few slides. I'd like to start by showing you that NAFLD is independently associated with subclinical arteriosclerosis that is diagnosed with various methods, including increased carotid intima media thickness based on ultrasonographic examination of the carotid artery, as well as based on increased coronary artery calcification measured by computed tomography scan. And studies have also shown that NAFLD is independently associated with arterial stiffness, which is measured by pulse wave velocity between the carotid and femoral arteries, as well as endothelial dysfunction, which is measured by a flow-mediated dilation. So besides cross-sectional studies showing association between NAFLD and subclinical arteriosclerosis, there is also a longitudinal study on a big number of patients who had NAFLD who did not have carotid arteriosclerosis at baseline. So after a follow-up period of 8 years, those patients who actually had regression of NAFLD were found to be less likely to develop carotid arteriosclerosis compared to those patients who continued to have NAFLD. And there have been also studies which shown that NAFLD is independently associated with clinically significant arteriosclerosis as indicated by high-risk plaque detected on computer tomography scan. So we have seen that NAFLD is independently associated with subclinical arteriosclerosis, both on cross-sectional study as well as on longitudinal study, and as well as clinically significant arteriosclerosis. But how about cardiovascular event and mortality? So this meta-analysis shows us that NAFLD is associated with significantly higher risk of both fatal as well as non-fatal cardiovascular event. And these events were significantly higher among those patients who had more severe NAFLD, defined by elevated GGT, a high NAFLD fibrosis score, or histological fibrosis. However, when they look at only fatal cardiovascular event, the association become non-significant. This is another meta-analysis which shows us that NAFLD is associated with increased risk of prevalent as well as incident cardiovascular disease, and that the more severe form of NAFLD or NASH is associated with even higher risk of cardiovascular disease. Again, we can see that the association between NAFLD as well as a fatal cardiovascular event become non-significant if only those fatal cardiovascular events were considered. This may be because there may be other factors which are more important than NAFLD that results in fatal cardiovascular event. But we can understand that a patient who have more severe NAFLD are probably those patients who are more exposed to metabolic factors and therefore have an even higher risk of getting cardiovascular disease and event. So not only that these patients have higher fatal and non-fatal cardiovascular event, after they have a cardiovascular event, if they have more severe NAFLD, it is also more likely that they have higher in-hospital as well as 3-year mortality. Patients who have ST elevation myocardial infarction, who has more severe NAFLD, also are those who are more likely to have absent myocardial perfusion, absent ST segment resolution, as well as higher in-hospital major cardiac event. So what can we do for our NAFLD patient? It's really important to assess whether they have cardiovascular disease. This particular paper has suggested an easy algorithm that we can apply to our day-to-day practice. So if you have a NAFLD patient and clinically it's evident that he has cardiovascular disease, of course, this patient should be referred to a cardiologist. But other things that we can look at in case they do not have evident cardiovascular disease is whether they have more severe form of NAFLD, in this case NASH or significant fibrosis, or if they have diabetes mellitus, or if based on certain scores, which I'll talk a bit more later, that there are increased risk of cardiovascular disease. This patient should undergo electrocardiogram, echocardiogram, and where available, some subclinical cardiovascular disease screening. And if these are positive, they should then be referred to a cardiologist. But if they are negative, this should perhaps be repeated every 2 to 3 years for assessment. In our NAFLD patients who do not have diabetes and has just simple steatosis without any significant fibrosis, and if the risk score that I'll be talking about a bit later is low, then we can perhaps reassess their risk every 2 to 3 years. So the American Association for Clinical Endocrinologists recommends that LDL cholesterol level should be treated to target based on individuals' cardiovascular disease risk. This is to reduce the risk of cardiovascular event and mortality. So the risk category can be divided into 5 based on the presence or absence of risk factors. And depending on the risk category, the level of LDL cholesterol that we would like to target will be different. So a person is considered low risk if there are absence of any risk factors, moderate risk if there are less than 2 risk factors, and the 10-year risk for cardiovascular event is less than 10%. They are considered high risk if they have diabetes or chronic kidney disease, or if they do not have diabetes but have at least 2 risk factors. They are considered very high risk if they have hospitalization for acute coronary syndrome, if they have diabetes or CKD with at least 1 risk factors, or if their 10-year risk is actually more than 20%. So what are the risk factors? Risk factors include high LDL cholesterol, cigarette smoking, low HDL cholesterol, hypertension, family history of coronary artery disease, less than 55 in a male and less than 65 in a female, chronic kidney disease, evidence of coronary artery calcification. And in case the HDL cholesterol is actually good, you can actually subtract 1 risk factor. So the risk score that I've been talking earlier, one of it that you can use is the Framingham risk score. This is readily available on your smartphone. There's an online calculator for it. So things that you need to key in to get the risk score would include age, the total cholesterol, the HDL cholesterol, the systolic blood pressure and whether the patient is on treatment or not, smoking status, as well as whether the patient has diabetes. So not too long ago, we actually conducted a multi-center study of biopsy-proven NAFLD patients. And what we found was that there was a gross mismatch between the prevalence of NAFLD as well as the use of statin in this population. So this is actually a retrospective study. And based on this finding, we actually proceeded with a prospective study, again, a multi-center study across several countries. Similarly, we found that the prevalence of NAFLD is high, but the use of statin for treatment of this patient is relatively low. And when we apply the Framingham risk score that I've shown you earlier and determine the threshold to treat the LDL cholesterol too, we found that among those patients who are not on statin, 59% of them should have been on a statin. And among those patients who are on a statin, 74% of them were actually not treated to target. So under prescription of statin in our NAFLD patient is really out there. So this perhaps may be due to several reasons. One of it is that as doctors who are seeing patients with NAFLD, there may be an underappreciation of their cardiovascular disease risk and therefore not treating their LDL cholesterol to the target that is supposed to be. The other possibility would be a concern that physicians have in prescribing statin to their patient with NAFLD, especially those who have elevated liver enzymes, due to concern about statin-induced liver injury. But studies have shown us that statin is safe and it's very rare to have serious adverse effect. And in fact, the use of statin in patients with elevated ALT, presumably due to NAFLD, not only improve their cardiovascular outcome, but results in improvement in their liver enzymes in many cases. Other things that we should consider in our patient with NAFLD is to be sure that their blood pressure and glycemic control is treated to target. A blood pressure of 130 or less than 130 over 80 is something that we should aim for. And HbA1c level of less than 6.5 is also something that we should be aiming for our patient, provided that it can be achieved in a safe and affordable manner. So I'd like to use a case to illustrate what I've been talking about earlier. So this is a 48-year-old gentleman with a BMI of 32. He has a history of hypertension and dyslipidemia and was just diagnosed with diabetes 6 months ago. So he is on metformin 1 gram twice daily, glycoside 160 milligram twice daily, simvastatin 20 milligram at night, and losartan 100 milligram daily. So this is his blood pressure, HbA1c, as well as cholesterol profile. So if we were to enter the variables that we need to calculate the risk score, we will find that this person is actually very high risk of cardiovascular disease of nearly 30% in the next 10 years. So this patient should have LDL cholesterol treated to below 1.8. So obviously the LDL cholesterol of 3.8 would not be satisfactory. And of course the HbA1c should be treated to a better level as well as the blood pressure. So over the next few minutes, I would like to talk about some novel anti-diabetic agent that would benefit our patient with NAFLD, not only in terms of the liver, but also in terms of the possible cardiovascular disease or the risk factor for cardiovascular disease that they have. So the first one would be a glucagon-like peptide 1 agonist, GLP-1 agonist. It acts by delaying gastric emptying, increasing insulin secretion, as well as reducing hepatic gluconeogenesis. And the LEAN study is a randomized controlled trial of overweight patients with biopsy-proven NASH. So patients were randomized to either liraglutide 1.8 milligram daily or placebo for 48 weeks. And you can see that patients who received liraglutide, significantly higher proportion of them had resolution of NASH, and significantly lower proportion of them had progression to fibrosis. So you can see that this medication appears which is licensed for diabetes, appears to be useful for our patient with NAFLD. And it also results in improvement in metabolic factors. BMI improves, the glycemic profile improves, the lipid profile improves as well. And there have been studies which shows that liraglutide significantly reduce death from cardiovascular causes, non-fatal myocardial infarction, as well as non-fatal stroke, compared with standard treatment. The next group of drug would be the SGLT2 inhibitor. Basically, it works by blocking reabsorption of glucose in the kidney, resulting in glucose excretion and lowering blood glucose level. Again, this is a medication license for diabetes mellitus. So we actually conducted an investigator-initiated single-arm open-label study not too long ago. We included diabetes patients with biopsy-proven NASH. They were given empagliflozin 25 milligram for 6 months, and they had a repeat liver biopsy at the end of the study. So as you can see, SGLT2 resulted in significant improvement in metabolic profile. Patients had significant reduction in body weight, blood pressure, glycemic profile, lipid profile. And patients also had significant reduction in volumetric liver fat fraction measured by MRI, as well as significant improvement in steatosis, ballooning, and fibrosis based on histology. And when we compare to historical placebo, the improvement in steatosis, ballooning, and fibrosis remains significant. So again, similar to GLP-1 agonists, there have also been very good data about SGLT2 inhibitor being helpful in cardiovascular disease. So empagliflozin has been shown to significantly lower rate of death from cardiovascular causes, hospitalization from heart failure, as well as overall mortality compared to standard care. In fact, these improvements can be seen as early as 3 months being on the medication. So over the next few minutes, I'd like to share with you my thought about NAFLD and cardiovascular disease. So in our effort to alter the natural history of chronic hepatitis B infection to reduce cirrhosis, decompensated liver disease, and liver cancer, we treat the hepatitis B virus infection with antiviral. And similarly, in our effort to fight chronic hepatitis C, we treat the hepatitis C virus with direct-acting antiviral. But in the case of NAFLD-related complication and mortality, most of our effort now has been focused on medication that actually work very downstream in the pathway of the disease. And even with novel anti-diabetic agent, and it's still working, it works slightly more proximal in the pathway, but it does not deal with the underlying issue, which is chronic overnutrition and obesity, and that really is the elephant in the room. So, because obesity, as mentioned by the first speaker, is a disease that affects so many systems. So, as a specialist dealing with different organs in the body, we tend to look at it as a disease that affects that part of the body. So, in the prevention of cardiovascular disease for a long, long time, the primary prevention focuses on preventing the onset of cardiovascular disease, while the secondary prevention focuses on preventing further cardiovascular event and mortality from recurrent myocardial infarction. But we learned from prevention of HBV-related liver cancer that primary prevention should really be preventing the risk factor. For example, we know that vaccination results in reduced hepatitis B virus infection. That should be the prevention. And perhaps in terms of preventing cardiovascular disease, the primary prevention should be preventing the onset of metabolic syndrome, whereas secondary prevention would be preventing the onset of cardiovascular disease, and tertiary prevention would be to prevent recurrent cardiovascular disease and mortality. So up till this point in time, the strategy to prevent NAFLD-related complication and mortality has not been defined yet. So do we want primary prevention to be preventing NAFLD patients from developing more advanced liver disease? And secondary prevention is to prevent them from getting complication and mortality, or do we choose that primary prevention to be preventing the onset of metabolic syndrome? I think this will be in our hands to decide in time to come and should be defined in our management of NAFLD and cardiovascular disease. This study has shown us clearly that lifestyle intervention works. For patients who are able to lose at least 10% of their body weight, you can see that 90% of them resolve NASH and 45% of them improve their fibrosis. And when we compare to the current drugs that are being investigated for the treatment of NASH, you can see that weight loss of more than 10% actually outperform any of the drug that is being studied at the moment. Unfortunately, only about 10% of patients are able to achieve the total body weight loss more than 10% that we desire in the management of our NAFLD patient. But perhaps that may be due to the way that we implement lifestyle intervention. So a lot of time when we actually tell patients to go on lifestyle modification, we actually put the entire responsibility in the patient themselves, on that particular individual. Sometimes we may actually refer them to a structured lifestyle program so that they have some help. But as you can see here, for example, in a study that we did across several centers in the Asia-Pacific region, only 1.6% of biopsy-proven NASH patients who have more severe liver disease were actually referred to a structured lifestyle program. Most of the time, patients are left on their own to try to achieve the lifestyle change that they need to overcome the disease. But we know in order to do that, it's actually more complicated. There are multiple factors that are involved, including social cultural factors, the community environment, up to government policy, as well as factors in a more global scale. So it is time that we need to get this message to our public health colleagues, people who are beyond the medical field, as well as policymakers, that their help is really needed for us to fight obesity. This is what we often see, at least in my country, but we should really be seeing more healthy eating, which starts from childhood. And this is also what we often see in the workplace, but perhaps we should see more of this. And this is the traffic in most Asian big cities. I think there need to be more walking that we need to do. And Mr. Chairperson, ladies and gentlemen, to conclude, I would like to say that NAFLD and coronary artery disease are the manifestation of the metabolic syndrome. Identifying and addressing component of the metabolic syndrome in NAFLD patient will help reduce the risk of cardiovascular disease. But prevention of metabolic syndrome is really an important and underutilized strategy in the fight against NAFLD and coronary artery disease. I'd like to just take this opportunity to invite you to the Asia Pacific Digestive Week this year, which will be in Kuala Lumpur from 17th to 20th September. With that, thank you very much.
Our last but not the least speaker is my co-chair, Dr. Rinaldi Lesmana, who's going to talk to us about NAFLD and non-alcoholic fatty pancreas diseases together in line. And we'll have questions afterwards if you're still awake.
Yeah. Thank you, James, for your kind introduction. Good evening, dear colleagues, ladies and gentlemen. So I just try to give talk as quick as possible, as we are running out of time, so we can have more discussion. So my task for today is about non-alcoholic fatty liver disease and non-alcoholic fatty pancreas disease. So I'm not sure how many of you in this room realize about this new clinical entity about the fatty pancreas disease or the steatosis. Yeah, okay, thank you. As we already known with all the previous speakers that NAFL is become a big problem at this moment as one of the major cause for the liver disease. And we know that also there's a possibility that cirrhosis-related complication, including HCC. And as also the previous speaker that Dr. Keong has already mentioned about the relation between the NASH and then the cardiovascular complication. And also the first speaker that has been also mentioned about the high prevalence NAFLD increasing in the Asia-Pacific region. And one of our recent study in 2015, based on the large cross-sectional and prospective validation study, so we can find that there's an increasing prevalence of fatty liver, because before that in our region, our country, Indonesia, that we found that NAFLD prevalence was only 30%, and now increasing until the 51% of patients. And some of them is already developed as a chronic parenchymal liver disease. And I just want to show that we know that even though the previous speaker has been mentioned about most of the metabolic factor has been related to the development of the NAFLD, and also the related to the NAFLD disease progression. And as we can see here, based on our recent study and published in 2015, that obesity or the high BMI seems to be the most important factor for the development of fatty liver.
Costas,
Yeah.
Cosmas, it's not.
Oh, sorry. So,
Slides are not progressing.
yeah, slides not progressive. So please, can someone help?
This is much clearer.
Okay. Yeah. So this, just skip this because I have mentioned about this, and yeah, this is a recent study, and yeah, this slide that I would like to show that BMI has been the most important factor related to the development of fatty liver disease. And of course, if we, as we can see here, other than the BMI, diabetes, and also the fasting blood glucose, it also has been the significant factors for the development of the fatty liver disease. So why we talk about the pancreatic lipomatosis or pancreatic steatosis or maybe the non-alcoholic fatty liver disease? Does it really matter in our clinical practice? We know that most of us that maybe our radiologists or maybe even hepatologists who like to perform the common, the usual transabdominal ultrasound, sometimes we only observe about the liver and maybe just a little bit about the pancreas. But we know that even just the transabdominal ultrasound, sometimes we found also the bright hyperechogenic pancreas. And previously or in the past, we are not sure yet what is the impact of the pancreatic steatosis or the pancreatic lipomatosis that has been also usually reported in the ultrasound report. So this just the nomenclature has been just recently published, proposed that about the pancreatic steatosis, pancreatic lipomatosis, or fatty pancreas. It's general term for the pancreatic fat accumulation, and also the fatty replacement and the fatty infiltration, and the non-alcoholic fatty pancreatitis disease that have been proposed for the nomenclature that is defined as the pancreatic fat accumulation plus obesity and the metabolic syndrome. And also the NASCP, that pancreatitis due to the pancreatic fat accumulation. So this review that we just recently published in the European Medical Journal of Gastroenterology in 2017 about the non-alcoholic fatty pancreas disease, pancreatic cancer, and the impact of endoscopic ultrasound examination on screening and surveillance. Why we make this review? Because we know that pancreatic cancer is one of the most lethal cancer in the world and has a very poor prognosis. We also know that early detection is very difficult due to the organ location and also the non-specific GI symptoms. So we know that it's not very ethical that to ask a patient to undergo such as a CT scan or MRI, even only with just a common dyspeptic symptom. And also sometimes the imaging limitation become a very big problem. So until now, we know the best tool for the screen or to see the pancreas is EUS or endoscopic ultrasound. However, it is very advanced technique. So, and we are not sure yet and very is ethical to ask patient to undergo the endoscopic ultrasound unless you're sure that the patient has a risk for the pancreatic cancer, or maybe the patient has a possibility of the chronic pancreatitis condition. And the problem also that most of patients already came in a late stage. And it has been known that early stage of the cancer, the pancreatic cancer, it has been defined as the precancerous lesion. So in the past, we know that the risk factors for pancreatic cancer is obesity, heavy drinker, and heavy smoker. And also that the important risk factor is the chronic pancreatitis, can be due to the gallstone disease, alcohol, and genetic pancreatitis disease. What about the fatty pancreas and diabetes? There have been the review about this, about the metabolic disorders and the pancreatic cancer, which has been published since 2002, about the relationship between diabetes and pancreatic cancer, also the diabetes mellitus and the cancer risk. One study from Japan that they found that there's a significant association of the pancreatic fatty infiltration with the pancreatic ductal adenocarcinoma. In this study, so more patients that underwent pancreatic resection, so they found to see that they look and they found that patient with the pancreatic ductal adenocarcinoma, when compared to other malignant type of the pancreas, has a higher fat content in the pancreas itself. And also in 2013, there has been a study to look at association between the non-alcoholic fatty pancreas disease and diabetes. As we can see here that between the NAFLD and fatty pancreas, there's almost similar significant, the association between the non-alcoholic fatty liver disease and diabetes, and also the non-alcoholic fatty pancreas disease and the diabetes. So we also published about the prevalence of non-alcoholic fatty pancreas disease and its risk factors among the adult medical checkup patient in our private hospital. As you can see here that for the development or the presence of the fatty pancreas in our patients cohort, we found is almost similar risk factor when compared to our patients cohort for NAFLD. So we found here that the body mass index or obesity and also the fasting blood glucose are the two most important factors for the development or the presence of the pancreatic steatosis. And also, you can see here that in addition, that fatty pancreas with normal liver was found in 16%, and then the fatty liver with normal pancreas was seen in the 39.4%. And there was a significant association between the fatty pancreas and the fatty liver in our patient cohort. Also, another study from one of my GI fellow past. So this is the study about the non-alcoholic fatty pancreas disease in type 2 diabetes mellitus patient. You can see here that there's a strong also association between the NAFLD and also with non-alcoholic fatty pancreas disease in type 2 diabetes mellitus patient. The last study that we've conducted that also have been presented in DDW in 2017 in Chicago about the non-alcoholic fatty pancreas disease as a risk factor for pancreatic cancer based on endoscopic ultrasound examination. And this is the characteristic of patient with and without pancreatic cancer. And we can see here, based on the bivariate and multivariate analysis, that pancreatic lipomatosis was the strongest risk factor for the pancreatic cancer. Of course, this study, because this is just a cross-sectional study, so it seems that until now we can see that maybe it has a strong association between the pancreatic lipomatosis and pancreatic cancer. And this, my last slide, just to give insight about the pathogenesis, about the pancreatic steatosis, which has been published in the American Journal of Gastroenterology recently, about how the pancreatic fat and then it can induce the inflammation, and then the fat accumulation in the pancreas also can induce the chronic pancreatitis. So I think the take-home message is NAFLD is an emerging disease and will become the first silent killer in the field possible of liver disease. And in the future, will be responsible for more liver transplantation. And non-alcoholic fatty pancreas disease, of course, maybe it's a forgotten one, maybe it's a new clinical entity, but we know that it might have an important role in our clinical practice. So choosing and educate the right patient is very important, and the comprehensive management, I think, is needed. So pancreatic cancer is rising, obesity crisis is also everywhere. Too much fat and glucose, we know that's a risk for cancer. And until now, the best screening for early pancreatic cancer is still unknown. So my message, just we need to eat less crap and then eat more food. So with that, I thank you very much.
Thank you. Any questions? If not, I have a question for Cosmas. So, sorry, while you're doing that. So what do you think is the clinical relevance of pancreatic steatosis? Because as we grow older, we get steatosis in our pancreas, and often it used to be treated as like nothing, an incidental finding. So what do you think we should be, and it's very difficult to get to the pancreas by ultrasound because there's a lot of bowel gas. So in what patients you should think that we should get a CAT scan or an MRI?
Okay, thank you. I think it's a very interesting and questions. Because I agree with you that even in our cohort, that I see that the more older patient and more they have the pancreatic steatosis. I mean the image of the hyperechoic pancreas. But in my opinion, most of patients with fatty pancreas disease, that especially that when they have the pancreatic cancer, mostly they also have like more a metabolic syndrome. So I know it's still difficult and debatable about how we evaluate the pancreas, especially the pancreatic steatosis, even not many centers also have a specific software for the MRI to quantify the fat in the pancreas. But I think, in my opinion, that if we have patient the same like fatty liver, so maybe patient have many metabolic other parameters that we need to be concerned, then maybe those patients that we need to consider to do the screening for the pancreas.
I have a question to Prof. Jasmohan. Thank you for excellent lecture. Recently, we have short-chain fatty acid tests taken from the stool. And it said that we can use short-chain fatty acid tests as the predictor that which patient need probiotic, and could be used also to measure the effect of probiotic. What's your comment on that?
So they are just one of the factors that can promote good health. And if you have high short-chain fatty acids, and by the way, the stool ones are a little difficult to, because those are already out of the body. So the ones that we really ideally want to measure is really in the portal blood, but that of course is impossible to do. But the serum ones are plasma ones are a little more important because that's what the body is still interacting with. That was just one of the ways of figuring out that if you give a probiotic to see if it is working or not, is one of the compounds that you can use that is produced by the bacteria most often by dietary fermentation. So it's not really that you can give the short-chain fatty acids and that will improve things, but it's certainly one of the many things that you can do. Ultimately, the endpoint has to be something clinical. So if you have a patient with NAFLD and you give them probiotics, the short-chain fatty acids go up, but the liver, it makes no difference to their liver enzymes or liver, or histology, then who cares, Ultimately, this is what you join the dots with to the clinical outcome.
Thank you.
Maybe one question for Dr. Heri Jagat and together with Dr. Kyo. So because both of you talking about the most metabolic risk factor in the NAFLD, so I just want to have both of your opinions about, do we need to do all the screening to all or every NAFL patient, or can you give some thoughts about maybe which NAFLD patient that needs to do screening, maybe only heart, or maybe all the screening tests that we should do, and which NAFL patient?
Maybe I can take the question first. We have a very high prevalence of NAFL in the population. So up 25-30% in the general population. Of course, we could not be applying very sophisticated tests for these people. So one of the things that the general practitioner can do would be to use non-invasive score. And for example, fibrosis 4 index. So if the score is less than 1.3, that's really a very low risk that this patient has advanced fibrosis and they need not be referred to.
I think the question was, in a patient with NAFLD, how much time should you spend looking at other organs? Basically, should you forget that you're a specialist and go back and becoming an internal medicine doctor, which is very boring. But
okay, so sorry, I misunderstood the question. But I think it doesn't take a very long time for you to assess for cardiovascular disease. If your fatty liver patient has diabetes, they are already at high risk of having cardiovascular risk factors. For example, if they have diabetes with hypertension, or if they smoke a cigarette, they smoke cigarettes, so they are already at very high risk. So, and of course, in this patient, you need to evaluate them with ECG, echo, and if there's any positive test, then you would refer them to a cardiologist. Some centers may have access to screening for cardiovascular disease with carotid intima media thickness or coronary artery calcification. So when these tests are positive, you can refer to your cardiology colleague for further management.
Okay. Maybe I have added of the question. For its mean in the general population, or also medical doctor, and maybe all specialists, if you find the NAFL in your patient must to be comprehensive approach for to think about the multi-system disease. Because like for cardiovascular, novel it is can before develop cardiovascular event after. And that's mean if you can find novel, must to measure about the how cardiovascular for system. Not waiting after later of the novel progress. Also, novel it is not only metabolic syndrome manifestation in the liver, but can lead and develop to metabolic syndrome. For cardiovascular, I think novel it's one of the independent risk factor for cardiovascular morbidity.
Maybe I can add on. I think one important thing is back to what I was saying earlier, which although it wasn't the question, is really to re-stratify the patient. Because as gastroenterologists and hepatologists, we probably should be seeing patients with more advanced liver disease rather than having too many patients flooding our clinic. So one way to do this would be to be able to have a general practitioner or primary care physician or endocrinologist to re-stratify the patient so that you only see those with indeterminate or high score, which you can then assess more accurately with, for example, FibroScan and do the necessary from there.
In our clinical pathway, we have them independently go through a FibroScan first. If the FibroScan is F2 or higher, then we see them in clinic. Otherwise, they go back to the primary care physician with the detailed thing about check for X, Y, Z, do your usual stuff. I mean, these patients, we don't have treatment right now. So we have that thing set up so that we only focus on the more advanced people.
Yes.
Not everyone who has.
I think your system is very good. You're very lucky that FibroScan is widely available.
It took a long time. It's most importantly. Okay, I think it's time for us. We are way, way over time. Thank you all for staying here, and thank you all for your enthusiastic response. And thank you all, and maybe see you next year in Bangkok, I guess.
Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Now we are facing the last symposium today, Symposium 10-1, with the topic of heart and liver. I'm Gontar Alamsah Siregar from Indonesia with Dr. Ricky Tenggara, also from Indonesia, will chair you for this session. We have 3 speakers this afternoon. One is Dr. Saleh Aman Nasution from Indonesia, and the second is Dr. Ian Homer Chua from Philippines, and the third is Irsan Hassan from Indonesia. The first topic is cardiohepatic dysfunction, interaction, pathogenesis, and clinical manifestation. Will give by Dr. Saleh Aman Nasution from Indonesia. Time is yours, Dr. Saleh.
Thank you, Mr. Chairman, Professor Gontar, and Dr. Ricky. Good afternoon to all audience. Assalamualaikum warahmatullahi wabarakatuh. This afternoon, I will present my topic about cardiohepatic dysfunction, about interaction, pathogenesis, and clinical manifestation. Ladies and gentlemen, liver disease is a common sequel of advanced, especially heart failure. Advanced heart failure range from the mild heart failure to the severe form of heart failure, and mostly in the severe advanced heart failure, we will find the cardiac cirrhotic, and we call in some studies. They call the cardiohepatic syndrome. This is interaction between the function of the heart and liver, as well as broad spectrum from acute and chronic entities that affect both these organs. And as we know that liver is have a unique circulation. He has two main circulation from the systemic and dual from hepatic, from portal vein and hepatic artery. And we know that liver will receive 25 to 30% of the total cardiac output from 2 vascular sources, that hepatic artery and portal vein. And in portal vein, they provide 70% of the hepatic blood flow. So if there is some disturbances from this organ, it will affect both cardiac and liver. This is prevalence of abnormal liver function tests that we will find to the patient with the heart failure hospitalized, if they have a hospitalized chronic or acute heart failure. And we see this from some abnormalities of liver function tests. The most function test is albumin, and then bilirubin, and LLT and SST as well. Some studies said that the use of this liver function test will be a marker for the prognosis of the heart failure, especially the advanced heart failure. Some cases we will find with advanced heart failure, they will have the very poor liver function, especially the bilirubin and ALT and AST. This is the one of the journal that the topic cardiohepatic interaction in heart failure. So in further discussion, we will focus for the cardiac disease in heart failure. For the recent treatment, future and recent treatment of the advanced heart failure now is heart transplantation. And many studies said that before the patient going to we prepare for the heart transplantation, they have to assess about the liver disease that the patient have. So we have to understand
what is the interaction between the heart failure and the hepatic function. We will see this one. This is the significant prognostic of marker that liver injury that we common finding in patient with the heart failure. We see this patient population with the heart failure with the NIHA from the class 3, 4, or the chronic heart failure. Usually we find the albumin level will be decreasing. And especially with the patient with the acute decompensated heart failure, which is acute decompensated is the patient with the chronic heart failure, and the patient will, in this acute situation, the albumin is one of the prognostic significance marker for the that heart failure. And this is the etiology. Why the hepatic and cardiac disorder may interact each other. As we know this, if is it the cardiac cause the liver disease, or liver cause the cardiac disease, or cardiac and hepatic disease a secondary each to share the etiology. For the first one, for the heart disease or heart situation or heart disturbance that cause liver disease, for example, heart failure is the most common causes. Condition with the liver, we call it hypoxic hepatopathy or congestive hepatopathy. We see this, there is two mechanisms for the disease interaction. The first one is acute cardiogenic liver injury, and the second one is the congestive hepatopathy. And we will find the first condition if the patient with the collapsed circulatory, patient with the shock, patient with the heart failure, acute heart failure, and other reperfusion injury. And the second one, in the congestive hepatopathy, we will find a patient with the severe heart failure. And this is the pathomechanism. We can see this. This is the echocardiogram. Oh, sorry. Yeah, thank you. Okay. This is the pathomechanism from congestive hepatopathy and hypoxic hepatopathy. From this figure, we can see the echocardiogram that show the enlarged of the right atrium and right atrium due to the high pressure of this right-sided. This is call it the right-sided heart failure, and we will see the congestive hepatopathy. And the second one, we see the abdominal echogram that's showing all dilatation, IVC, and right hepatic vein and middle hepatic vein. And this is the pathophysiology of liver dysfunction in heart failure. We will see the increase of central venous pressure. It will make the congestive hepatopathy, and we find the reduction of the arterial perfusion, and this is due to acute cardiogenic liver injury. Sometimes they call it shock liver. For acute cardiogenic liver injury, diagnosis is based in setting. Is it cardiac problem, circulatory problem, or pulmonary failure? And we will find the aminotransferase level usually is very high, more than 20 times the upper limit. And we have to exclude the other causes of liver damage. And in these cases, in cardiogenic liver injury, often the patient remain asymptomatic. Sometimes patient exhibit sign and symptom like acute viral hepatitis. But this condition has a high mortality, and the management focus, we have to, according to the underlying acute disease like heart failure. For the congestive hepatopathy, patient typically presents with the sign of cholestatic enzyme, predominance cholestatic enzyme, and often congestive hepatic and renal dysfunction coexistence. Signs and symptoms concomitant by right heart failure. So we have to do the ultrasound, echocardiography, and sometimes we need liver biopsy. Diuretic is the mainstay of the treatment for this condition, and for a patient with the need mechanical support, inotropic therapy, or sometimes they need LVAD for the heart failure. This is the congestive hepatopathy that I mentioned before, that patient typically present with the predominance cholestatic enzyme, increasing cholestatic enzyme, and sometimes we find the congestive hepatic and renal dysfunction as well. This is the comparison between acute and chronic complication of cardiac failure. We will see this is the chronic condition, and this is the acute ischemic hepatitis. And we see that most of the patient with chronic heart disease, chronic heart failure, we will find the increasing of liver function tests. And sometimes we find the patient will with jaundice. The second one is liver causes cardiovascular disease. The most common problem is cirrhotic, and we call it cirrhotic cardiomyopathy. And other condition is novel or non-alcoholic fatty liver disease. And this is liver causes cardiovascular disease. We call it cirrhotic cardiomyopathy. And up to 50% patient come with cirrhosis. And cirrhotic cardiomyopathy has recently been defined as follows. The first one is we find the systolic dysfunction of the cardiac. And second one, we find the diastolic dysfunction. And the third one, sometimes we have abnormality of electrophysiology disturbance that so patient with the arrhythmia from it's starting by benign to malignant arrhythmia, and sometimes we find the increasing of the the NT-proBNP and troponin level of this patient. This is the stage. As we see here, this is normal heart, and this is the cirrhotic cardiomyopathy. And starting with the reduce from the systemic vascular resistance in patient with portal hypertension in cirrhosis, and it will cause the elevated cardiac output, hypertrophy, and we see this LV mass index will be increasing. And then it caused by hyperdynamic syndrome, impaired diastolic dysfunction, and the patient will have symptom exercise intolerance, and sometimes we find the QT prolongation by the ECG. And if there is precipitating factor, and the patient will be heart failure or pump edema with the hypotension or shock cardiogenic. And if this patient have the transplantation, we will find the systemic vascular resistance will be decreasing, and the cirrhotic cardiomyopathy will be improving. This is the pathophysiology and diagnostic methods of cirrhotic cardiomyopathy. This is some cardiac abnormality, and that we'll find in this condition. QT interval prolongation due to electrophysiology disturbances and mechanical dissociation, and as well dysfunction of diastolic and systolic of the heart. And this is we have to, the patient have to perform the resting electrocardiogram. If is it possible, they do the exercise test, and then the non-invasive procedure like the echocardiography, or sometimes you have the patient have to perform the MRI. This is the liver causes cardiovascular disease. The most etiology is heart failure in NAFL or heart failure in non-alcoholic fatty liver. In these cases, the most frequent liver disease characterized by accumulation of liver fat. And if we see this patient usually have other risk factor of cardiac, like obesity, disturbance of lipid profile, and other risk factor due to cardiovascular event in the future. This is a schematic that we see the mechanism underlying the contribution of novel disease to the increased risk of the cardiovascular disease, chronic kidney disease as well, and other structural. And also we find the complication of arrhythmia in cardiac. We see this one in novel disease. There is insulin resistance, atherogenic dyslipidemia, increasing of inflammation and oxidative stress, hypercoagulability state, and hypertension. And all these conditions will be the risk factor to further cardiovascular event in a patient with NAFL disease. This is metabolic syndrome, like underlying pathophysiology in NAFL disease and cardiovascular disease in the future. This is the liver causes cardiovascular. Heart failure after liver transplantation, they said, may occur early, less than 30 days, or late, more than 30 days after liver transplantation, and this is accompanied by high mortality. So they said that several studies said that patients with plan to transplantation, they have to perform the procedure to assess the function of the cardiac, especially the diastolic dysfunction, not only the systolic dysfunction of the cardiac. And this is risk factor associated with the heart failure after liver transplantation, and we have to make assessment before the patient perform the transplantation. And impact of cardiogenic liver disease on drug metabolism and effect. The most important thing is hepatic drug clearance. This is abnormal hepatic drug metabolism is related to the severity of heart failure, and it will be improving after heart failure management, especially the optimal medical therapy. In future perspective, they say they stop gene therapy and butyrate for the gut microbiota for heart failure development. And this is the relationship between intestine and liver, gut-liver axis. And this is the common condition that affect liver and heart concomitantly. Some of disease is congenital disease, and in Indonesia, maybe the infection disease will be increasing. For example, in dengue fever, some patient with dengue fever, we will find concomitantly with the myocarditis. And for example, patient with the systemic lupus erythematosus, we will find patient with the pericarditis or endocarditis. For conclusion, we know that the heart and the liver are in close relation to each other, and liver hypoperfusion and hepatic congestion are the two central pathophysiology mechanisms, both in acute cardiogenic liver injury and hepatic congestion. And for cirrhotic cardiomyopathy is a syndrome that includes systolic, diastolic, and electrophysiological abnormality that develop in the setting of liver cirrhosis. And for these cases, we need the good collaboration of the team between hepatologists, cardiologists, and internal medicine, and needed in this category for patient for better diagnosis, treatment, and prognosis. Thank you very much for the attention.
Thank you, Dr. Saliana Sution, for the very good presentation. Okay, please sit down here. For the next. Okay, okay, it's okay.
Press this one.
For the next speaker is Ian Homer Yechua from the Philippines with the topic of myocardial dysfunction associated with the hepatitis B virus infection.
From the beginning.
Okay. Dr. Homer, please.
Good afternoon, ladies and gentlemen. First and foremost, I'd like to congratulate Professor Rino Gani and the Apostle 2020 Bali team for a very successful meeting. So this afternoon, I will present to you evidence on the relationship between chronic hepatitis B and cardiovascular outcomes such as dyslipidemia, atherosclerosis, coronary artery disease, arrhythmia, and myocardial infarction. Last but not the least, I'll be talking about cardiovascular outcomes and all-cause mortality in patients with chronic hepatitis B. So this slide shows to us the potential mechanism in hepatitis C patients and cardiovascular disease. So either it will cause indirect viral effect to the liver, causing chronic viral hepatitis leading to hepatic insulin resistance, and therefore can produce metabolic steatosis, inflammation, and thereby will go into the different inflammatory pathways involving oxidative stress, fibrosis progression, and diabetes mellitus. And there's some evidence that's showing that hepatitis C can also cause a direct viral effect, causing chronic local systemic inflammation, leading to atherosclerosis, ischemic stroke, and cardiac disease. And my topic this afternoon is looking at the relationship between hepatitis B infection and cardiovascular disease. So first, we're going to talk about hepatitis B and dyslipidemia. So a study published 7 years ago, they looked into the combined effects of chronic hepatitis B and elevated ALT on dyslipidemia. A total of 7,695 patients were enrolled after an annual health examination. So these are the criteria for the diagnosis of dyslipidemia. And they look at the association between dyslipidemia, hepatitis B, and elevated ALT. So looking at this table, they computed the odds ratio between abnormal lipid profiles for hepatitis B infection, serum ALT, and the interaction between hepatitis B infection and serum ALT. As you look into the table, there's no relationship between hepatitis B and dyslipidemia. However, there's a relationship between ALT, the elevated ALT, and dyslipidemia. And if we combine hepatitis B and ALT, there's no relationship at all. So looking at the specific groups, so they subdivided the group into those with or without hepatitis B and those with elevated ALT or a normal ALT. So if we concentrate in the groups 2, wherein patients had hepatitis B with no elevation of ALT. As you can see here, the odds ratio is less than 1, so there's no association between hepatitis B, normal ALT, and dyslipidemia. Looking at Group 4, wherein they combine hepatitis B and elevated ALT, as you can see here, the odds ratio crosses the middle line, which is 1, so I think there's no significant difference at all. So in conclusion, what is the evidence out there with regards to hepatitis B and atherosclerosis? So in this particular study, hepatitis B infection was not associated with hypercholesterolemia, hypertriglyceridemia, and high LDL-C levels. And elevated ALT levels were positively associated with all the dyslipidemia criteria, including hypercholesterolemia, hypertriglyceridemia, high LDL, and low HDL. And then if you combine hepatitis B and elevated ALT, there's an opposite effect on the most of the dyslipidemia criteria, whereas the interaction between hepatitis B and the elevated ALT resulted in a very low odds ratio for hypertriglyceridemia. So we need further studies to investigate this association. So second is we're going to look at the association between hepatitis B and atherosclerosis. So previous studies have shown that the association between hepatitis B and atherosclerotic disease showed conflicting results because most of the studies are cross-sectional or retrospective in design. And then we need to have a more robust study design to determine the association instead of a causal temporality. So existing data indicate that both viruses and bacteria can contribute to the initiation and progression of atherosclerosis. However, studies have shown that viruses appear more frequent to predispose to plaque rupture compared to bacteria. So looking at the evidence, this is a study based on the REVEAL trial, wherein they look at hepatitis B and the risk of atherosclerosis-related mortality involving 22,472 residents in Taiwan. So this is the study design on the right hand of the screen. If we look at the evidence, so these are the patients with seronegative HBs antigen, with HBs seropositive, and the hazard ratio for patients with hepatitis B. So if you look closely to the hazard ratio with regards to the cardiovascular events, so there's no significant association between hepatitis B and all these cardiovascular events, except for liver disease, wherein we all know that Hep B can lead to chronic liver disease and then can lead to more fibrosis and cirrhosis. And then concentrating on this particular data, if you look into the specific association, looking at the hazard ratio, so there's no significant association between hepatitis B and ischemic heart disease, cerebrovascular disease, and all cardiovascular disease. So in this particular study, it has been shown that if you had hepatitis B, it was not associated with increased risk of atherosclerosis-related or cardiovascular mortality, and then therefore they recommend that routine screening of hepatitis B infection could not be recommended for patients with cardiovascular risk. And in addition, there's also a meta-analysis looking at the relationship between the exposure to hepatitis B virus and increased atherosclerosis-associated morbidity. As you can see here, hepatitis B may not be a risk factor for atherosclerosis-associated disease, so we need more studies to employ more sensitive clinical parameters to verify these results. And then what is the evidence between hepatitis B and coronary artery disease? So there's one particular meta-analysis looking at this association. So this is a study design of this meta-analysis. As you can see here, hepatitis B infection does not increase the risk of coronary heart disease, so we need to have more large prospective studies to investigate this relationship. And how about looking at the association between hepatitis B and cardiac arrhythmia? So this is also one study wherein they look into the risk of cardiac arrhythmias in patients with chronic hepatitis B and C. So this is a 13-year nationwide population-based study involving almost 12,000 patients. So as you can see in this particular graph, you look at the all-cause mortality. So patients with hepatitis B are more prone to have all-cause mortality due to cardiac arrhythmias compared to patients with chronic hepatitis B. So in addition, in this particular study, as you can see with the graphs, patients with hepatitis C infection were associated with significant increased risk of sinus 6 syndrome and all-cause mortality compared to patients with chronic hepatitis B. And how about looking at the evidence with regards to the relationship between hepatitis B and myocardial infarction? So this is a study published almost 4 years ago looking at the long-term outcomes among patients with acute myocardial infarction. So in this particular slides, it has been shown that there's no significance whether the patient has hepatitis B or no hepatitis B in the male patients. However, in this particular study, it has been shown that female patients who develop AMI has a lesser chance of survival, particularly if they have hepatitis B. And then moving forward, so this patient underwent PCI. So for patients who underwent PCI, so there's a greater chance for them to survive compared to those who did not undergo PCI. And then in particular, wherein they look at the survival curve of AMI with PCI management, whether the patient has Hep B or Hep C, there's no significant difference once a patient had PCI. So in this particular study, it has been shown that there's evidence of a possible effect of hepatitis B infection on the survival of women who have first AMI. So independent of the gender and hepatitis status, PCI management plays an important role in the long-term outcome of this patient. And last but not the least, I will be discussing the association between hepatitis B and cardiovascular outcomes. So this is coming from the same study from Taiwan. So in this particular study, they compare hepatitis B and hepatitis C. So patients with hepatitis B infection had a significant higher risk of developing cardiac events and all-cause mortality compared to patients with chronic hepatitis B. And then in another study wherein they look at the impact of hepatitis B infection on major adverse cardiovascular events and all-cause mortality in patients with diabetes. So this is the study design. Almost 90,000 patients were involved in this study. So if you look at the evidence, so patients with hepatitis B and diabetes has a higher risk of all-cause mortality and also the major adverse cardiovascular events compared to the matched cohort. So in this particular graph, as you can see, chronic hepatitis B was associated with decreased risk of heart failure and all-cause mortality in patients with diabetes. So, Mr. Chairman, in conclusion, so the present evidence have shown that chronic hepatitis B was not associated with increased risk of dyslipidemia, atherosclerosis, coronary artery disease, arrhythmia, myocardial infarction, and CVS mortality. It has been shown that patients with hepatitis C were associated with a significant risk of developing cardiac arrhythmia, such as sinus syndrome and all-cause mortality compared to hepatitis B patients. And patients with hepatitis infection had a significantly higher risk of developing cardiac events and all-cause mortality compared to patients with hepatitis B. And at this point in time, routine screening of hepatitis B infection would not be recommended for cardiovascular risk assessment. Thank you very much.
Thank you, Dr. Ian Homer. You have to sit here beside us because this last session. We invite the third speaker, Dr. Irsan Hasan from Indonesia, this time for yours.
Thank you, Professor Gontar and Dr. Ricky. Good afternoon, everybody. This is my last topic, and I am also the last speaker in this session, also in the meeting. My topic is exercise for liver cirrhosis patients. So let me start with the story about exercise in the field of hepatology. Nearly 20 years, exercise was not recommended for liver cirrhosis based on two reasons. First, there are studies found that acute increase is happened in hepatic vein pressure gradient during exercise. And increased HVPG prevented with beta blocker before exercising. So it showed that there is potential benefit of variceal bleeding on cirrhosis patient during exercise. But the new studies showing that exercise was safe and has potential benefit for cirrhotic patients, such as improvement in cardiopulmonary, metabolic function, and quality of life. And it is found that even there is HVPG increasing during exercise, but in the long term, HVPG will be decreased. So for the next 20 minutes, I will focus on physical exercise, and I divide my talk into three parts: physical inactivity in cirrhotic patients, benefit of exercise, and exercise prescription. Let me start with physical inactivity in cirrhotic patients. This is a schematic diagram of effect of physical fitness and nutritional status and the condition of liver cirrhosis patient. We can see here that physical deconditioning can be affected by cardiopulmonary endurance, and also the functional deterioration can be affected by these two conditions: cardiopulmonary endurance and sarcopenia. And to have cardiopulmonary endurance, the patient needs good physical activity and exercise. So this slide shows the interdependence between physical fitness, nutritional status, and functional deterioration. And this slide shows the relationship between physical activity, exercise, and physical fitness. Any body movement as the physical activity, and plan structure and physical activity to maintain physical fitness or exercise will affect the ability to carry out daily tasks. Physical inactivity is an independent predictor of morbidity and mortality in patients with cirrhosis. Overall, physical activity levels in cirrhosis are low. More than 70% of waking hours in liver cirrhosis patients are spent in sedentary state, so in the state 0 to state 3. They only do sedentary behavior or light physical activity. And patients with cirrhosis show a reduced tolerance to exercise due to a decrease in aerobic capacity assessed by VO2 peak. VO2 peak in patients with liver cirrhosis is inversely correlated with liver function, MELD or Child-Pugh score, meaning that the higher Child-Pugh score, the lesser, the worse the VO2 peak. The cause of aerobic capacity reduction in cirrhosis is multifactorial, such as fatigue, disturbances of carbohydrate metabolism, reduced hepatocellular function, sarcopenia, and protein energy malnutrition, and decreased cardiopulmonary reserve. This paper tried to explore the correlation between fatigue and physical inactivity. They use fatigue symptom inventory, or FSI, to measure the fatigue level. The higher scores indicate a greater fatigue level of or interference. And they found that the weekly physical activity levels were higher in men, married patients, I don't know why married patients, and patients with normal hemoglobin, hematocrit, and white blood cell counts. So female and unmarried and patients with anemia, low hemoglobin have to be careful because they have low physical activity. So I think it's recommended, we have to recommend our patient with cirrhosis to get married soon. And this is the conclusion of the authors. Cirrhosis patients experience severe fatigue with reduced level of physical activity. Early evaluation of fatigue level should be conducted in the clinic. Individualized instruction for patients' physical activity should be provided. And now I move to sarcopenia. Sarcopenia is a generalized reduction in muscle mass and function due to aging. This is primary sarcopenia. And secondary sarcopenia, acute or chronic illness, including chronic liver disease. Sarcopenia causes physical inactivity, and physical inactivity further contributes to development of sarcopenia. Clinical implication of sarcopenia associated with a higher rate of complications such as susceptibility to infection, hepatic encephalopathy, and ascites. So this is sarcopenia in liver cirrhosis patient. And sarcopenia also independent predictor of lower survival in liver cirrhosis and patients undergoing liver transplant. Current research also showed that sarcopenia is a predictor to the HCC patient underwent surgery or locoregional therapy. And sarcopenia will give some adverse outcomes on cirrhotic patients, like higher mortality, higher risk of hepatic encephalopathy, longer ICU stay, and higher incidence of bacterial infection. There are many hypotheses on the risk or the cause of sarcopenia. This morning we heard from Professor Jasmohan about the Professor Eddy about the myostatin, ammonia, inflammation, mitochondrial dysfunction, and other factors. But I have to focus in disuse or inactivity factors as the risk of sarcopenia. 50% of patients with liver cirrhosis may present with cirrhotic cardiomyopathy. It has been mentioned by Dr. Sali, which contributes to decreased aerobic capacity and reduced tolerance to exercise. Cirrhotic cardiomyopathy, or CCM, is defined as chronic cardiac dysfunction in patients with cirrhosis and characterized by systolic dysfunction, diastolic dysfunction, and ECG abnormalities. And I will move to the second part, benefits of exercise in liver cirrhosis. There are some potential benefits of exercise in liver cirrhosis, and it could be divided into two parts, central adaptation and peripheral adaptation. For central adaptation, for example, increase of ejection fraction, increase of stroke volume, increase maximum cardiac output of heart, and vascular, increase systemic arterial compliance, increase endothelium-mediated vasodilation, and other benefits. Peripheral adaptations can be have from the brain, liver, adipose tissue, metabolism, muscle, and also the bone. This slide shows the effect of exercise on cirrhosis. At the beginning of my presentation, I mentioned about the dangers of exercise for the patient with cirrhosis, because it could increase the HVPG, hepatic vein pressure gradient. So in patients with portal hypertension not taking beta blockers, exercise could lead to increased risk of variceal bleeding due to transient HVPG during exercise. But recent studies found no episodes of variceal bleeding with 8 to 16 weeks of moderate exercise. A decreased HVPG was observed after chronic exercise. This review shows the clinical trials exercise and the effect of exercise on cirrhosis. So exercise will increase muscle mass, improve general health and social function, improve peak VO2, increase daily steps, and hand grip strength. This is systematic review of exercise as an intervention for patients with end-stage liver disease. And the author conclude that exercise in selected cirrhosis patients have potential benefit without adverse effect from exercise. So the goal of exercise is different between a compensated and decompensated cirrhosis. For compensated cirrhosis, the goals are increase aerobic capacity, VO2 peak, and to prevent sarcopenia. And for the compensated cirrhosis, the goals are attenuate muscle mass loss and prevent hepatic encephalopathy. And after so many trials, so many publications, so there are enough evidence to put exercise in liver cirrhosis guidelines. The first guidelines included exercise is EASL guidelines on 2018. So based on EASL guidelines, there is a recommendation on exercise. Increased physical activity and exercise are anabolic stimuli that can improve muscle mass and function. There are two types of exercise, endurance or aerobic exercise and resistance exercise. For endurance or aerobic exercise, it will improve skeletal muscle functional capacity, but not necessarily muscle mass. So the function, not necessarily the muscle mass. And for resistant exercise, it will promote increase in skeletal muscle mass. So resistant exercise will give benefit on muscle mass. We can find the recommendation on EASL guidelines that mention that patients with cirrhosis, whenever possible, can be encouraged to avoid hypomobility and to progressively increase physical activity to prevent and or ameliorate sarcopenia. My last part is exercise prescription for liver cirrhosis. How to advise our patient to do exercise, even we are ourselves, the doctors, not doing exercise. Prescribing exercise for liver cirrhosis involves a three-step process. First, screening to minimize exercise related adverse events. The second, baseline physical capacity assessment. And the third, exercise programming with subsequent monitoring. First, screening. There are three parts on screening. The first, cirrhosis-related screening. Patients with high-risk varices, FibroScan more than 20 kilopascal and platelet count less than 100, FibroScan more than 20 kilopascal or platelet count less than 150,000, not receiving primary or secondary prophylaxis are contraindicated for exercise programs due to risk variceal bleeding. Large volume ascites, ankle edema, and hepatic encephalopathy are not absolute contraindication for exercise, but can impact efficacy, adherence, and tolerability of exercise. Cardiopulmonary screening should be done for patients starting moderate intensity program with the following signs and symptoms and medical conditions. Method of screening is up to the physician, but I recommend to send to Dr. Sali to do the screening, not to screen by ourselves, the hepatologist. Non-vigorous physical activity do not need prior cardiopulmonary screening. So moderate intensity exercise, as mentioned below, 40 to 90% heart rate reserve and VO2 reserve and rate of perceived exertion. I will explain more about the moderate exercise. Vital signs should be measured in all patients. All patients should be screened for exertional symptoms that limit activities of daily living, musculoskeletal limitation, and fall risk. And next, a physical capacity assessment. Two important purposes of assessing baseline physical performance are evaluation of cardiopulmonary endurance and capacity to exercise, establish an objective baseline against which progress can be measured, and these are tools for evaluation of baseline physical capacity or performance. And now we come to exercise program. Principles of exercise training in liver cirrhosis are start low, progress slowly, and be alert for symptoms. Follows FITT principles. Perform non-exercise activity thermogenesis or NEAT. Schedule exercise programs which include warm-up exercise and cool-down phase. Exercise training should be accompanied by proper nutritional intervention or sport medicine specialist. This is FIT principles of exercise: frequency, intensity, time, type, and time for aerobic and resistance type of exercise. This is FIT for aerobic. The frequency start with 4 days a week, aim to do every day. Intensity, moderate intensity. How do we know that this is moderate intensity? The patient should pass the talk test, be able to speak comfortably during exercise. So the patient should be can speak in comfortable condition during the exercise. So maybe you should accompany the patient and try to talk to the patient. And the type, start with walk 1 minute, rest 1 minute, and repeat until total 5 minutes. Build to 40 minutes in each session. Time, walking, indoor or outdoor, or other activities. And this is the resistance type. Frequency, 2 or more days per week, non-consecutive days. So exercise, rest, and exercise. Intensity, perform with exercise resistance hand, and rest is needed after 1 to 15 repetitions. So it's called one set for 10 to 15 repetitions. Increase the stiffness when 3 sets can be completed easily. So increase the level, the stiffness after 3 sets can be completed easily. Type start with 3 to 4 exercises per session, increase to all 7 exercises a day. Time, progressive weight training activities. And the next is non-exercise activity thermogenesis, non-exercise, so it's a need. This is continuous and vital low-intensity movement. Physical activity in day-to-day routine which complement exercise and results in more sustainable increase in activity level. This is the examples: parking farther away, washing dishes instead of using the dishwasher, climbing stairs instead of taking the elevator. So I recommend you to go by walk when you go back to your hotel, not by car. And how to monitor the heart rate during exercise. Goal of heart rate during exercise is 60 to 70% of the maximum heart rate. This is the formula to calculate the heart rate. And don't forget the nutritional intervention. Exercising under insufficient nutrients and protein intakes could be dangerous in patients with decompensated cirrhosis, as exercise could promote further protein catabolism and loss of muscle mass. So intake of liver cirrhosis patient undergoing exercise program should be achieve this target as mentioned in the tables. But one thing that should have our attention, that additional caloric intake pre and post exercise should be given. Additional 250 or 300 kilocalorie of carbohydrate based caloric intake. And this is the picture of exercise and nutritional intervention in liver cirrhosis. So the complexity of the exercise should be adjusted depend on the severity of the disease. And also nutritional intervention should be given to the patient with physical exercise. And don't forget the integral plan. We should invite our colleagues, cardiologists, sport medicine, nutritionists, if we advise physical exercise to our patient. And as the summary, this is the exercise model for liver cirrhosis based on the type: aerobic training, resistance training, and balance and strength. And don't forget the nutritional intervention during exercise. And this is the impact, the outcome: metabolic complication from portal hypertension, weightless survival, and also post-transplant complication. So, Chairperson, dear colleagues, this is my conclusion. Physical inactivity and sarcopenia are independent predictors of mortality in patients with liver cirrhosis. Trials show that 8 to 16 weeks of supervised exercise is associated with increased aerobic capacity, muscle mass and strength, and health-related quality of life. Though exercise can cause a transient rise in hepatic vein pressure gradient, chronic exercise results in decrease at VPG. Screening and baseline assessment of physical capacity is important before prescribing exercise programs to patients. Aerobic and resistant exercise, along with flexibility and balance training of moderate intensity and nutritional interventions, are recommended in patients with liver cirrhosis. Thank you very much.
Thank you, Dr. Irsan Hassan. Very interesting lecture. Now we are going for discussion. Please, anybody want to give a question for our three speakers? Have time?
Okay, any question?
Yes. maybe it's the last session. Everything clear.
I have one question maybe.
Yeah, please.
For Dr. Isan and maybe Dr. Sali. Okay, the patient with the liver cirrhosis sometimes develop cardiac cirrhosis. And you recommend that the patient with ejection fraction is about more than 55%. Is there any specific ejection fraction for the liver cirrhosis patient? Maybe you recommend this is may not be not so fit for the exercise. Okay.
Thank you, Dr. Ricky. It's a difficult question. Yeah. Yeah, there is no specific threshold or a level of the ejection fraction. It's same with the common threshold that we classify the ejection fraction normal if the ejection fraction 50% or more than 50%. And we know that most of the patient with the cirrhotic cardiomyopathy, they're starting not from the systolic dysfunction, but diastolic dysfunction. We have to know about the diastolic function as well from the echo, not only the systolic function. So for the patient with the chronic liver disease like cirrhotic, especially with the cirrhotic cardiomyopathy, if the patient perform the echocardiogram, we have to know about the diastolic dysfunction as well, not only the systolic function. Thank you. Yeah, because sometimes patient with diastolic dysfunction and normal systolic dysfunction, it's normal systolic function, but they have clinically heart failure. So because heart failure is the clinical diagnosis, I mean, if the patient already have the sign and symptom of heart failure, but systolic function is still good, we have to match the exercise, not only based on the systolic function. Thank you.
Yeah, thank you, Dr. Ricky. There's no specific recommendation for the type of exercise for the patient with cirrhosis cardiomyopathy. But the important thing is to assess the heart condition before advise the patient to do exercise. So as mentioned in my presentation, we should assess whether this patient have cardiomyopathy or have some cardiac problem. That's why I thought that sometimes we should send to our colleagues, cardiologists, to assess the patient is high risk for exercise or not. So the answer based on cardiologist, Dr. Sali.
Okay, thank you very much. Yeah, please.
Thank you to Dr. Irsan. What kind of exercise you suggest for the patient of ascites? First. And second, what kind of the nutritional intervention to support exercise program in liver cirrhosis? Thank you.
Thank you, Dr. Dasril. Yeah, the patient with decompensated cirrhosis, as I mentioned, some studies show that even to the patient with decompensated cirrhosis, it's still recommended to do exercise. But of course, this is with low intensity exercise. Ascites in liver cirrhosis is divided into three stages. 1, 2, and 3. And we know that the stage 3 with very large ascites cannot recommended to do the exercise. But for stage 1, stage 2, maybe exercise can be started. What kind of exercise? No specific recommendation, but I think based on the type of exercise, we can start with walking, just walking. So ask the patient to walk 5 minutes walk, and we have to monitor and evaluate what happened after walking 5 minutes. So if there is shortness of breath, we have to stop the exercise. And the second about nutritional intervention. First, we need to do a basic nutritional intervention like protein and also late evening snack. This is a basic intervention. But as I mentioned from the guidelines, we should add the calorie, the nutrition for the patient with moderate exercise. So they give recommendation to give carbohydrate 200 kilocalorie for every exercise. Thank you.
Yeah, thank you. Thank you very much for the question. Thank you very much for all the speaker, and give applause to the speaker, our speaker. And we close this session. Thank you very much for the audience. Assalamualaikum warahmatullahi wabarakatuh.
Mais uma boca.